Yes. I feel like it's apropos that we are about to talk about the workforce pipeline, and you got to meet some of the next generation of those healthcare leaders, and Xavier is doing an excellent job, and we also on our panel have one of their newest graduates as well. So we are excited to have each and every one of you here with us to talk more about health equity at work, building the pipeline for a diverse workforce, and we also are virtual as well, so if you're joining us on Zoom, thank you. We're gonna start by doing a quick kind of thought starter, getting our juices flowing. I know we just came from lunch, and I thought it was very well timed because we did earlier hear the question about what's working, right? And I'm excited because with healthcare workforce diversity, we have made strides and we have seen outcomes improve for patients in a number of areas. So I wanted to first ask each of you to think, and if you think it's yes, you can raise your hand or stand up if you want to get your juices flowing. If you're on Zoom, you can raise your hand on Zoom as well. So the question is the diverse health workforce pipeline increasing? If you believe that it is, that we are making improvements, raise your hand or you can stand for yes. And I'm gonna, if you think no, you can just stay seated or not raise your hand. So let's see. Oh, we've got 1 hand, 2 hands, 3 hands, 4 hands, excellent. And in the Zoom? No hands. Okay. So our 3 hands are actually correct. I'm not sure if you saw, but according to the AAMC study in December of 2021, it was released. Applicants to medical schools are actually soaring, and a record-setting number of 17.8% for this school year have actually led historical increases in underrepresented minorities into medical institutions. So this is an example of all of the work that we've done together collectively driving that progress. And indeed, we're going to talk more about moving from admiring the problem and getting down to solutions today. So thank you for kind of starting off with that thought starter. I'm Shyrea Thompson. I am the founder and principal of the IRIS Collaborative, and we actually bring profit and purpose together to drive social good. And I'm honored to also be a National Minority Quality Forum Advisory Board member and an inaugural 40 Under 40. I know I'm here with another fellow one as well. So we're just excited to sit down and have this conversation. So we're gonna start off by introducing our esteemed panelists. I'm here today with Dr. Ulysses Burley, who's the founder of UB The Cure, LLC. And he'll share more about his work shortly. Also, Dr. Kanan Cavalier. He is our newest pharmacist at Ochsner Medical Center right here in New Orleans. Miss Molly Ryan is joining us on Zoom. So if you see over there, thank you, Molly, for coming in from the DC area. She is the Vice President of Government and Policy Affairs for Global Blood Therapeutics. And then we have Dr. Veronica Sandoval, who's joining us. She is the Principal of Patient Inclusion and Health Equity at Genentech. Thank you, Dr. Sandoval. And then Ms. Quovitis, who is Ms. Quovitis Webster, and she goes by Ms. QV. She is the Director of Pre-Med Programs, also right here at Xavier University of Louisiana. So thank you so much for joining us. We're gonna actually go ahead and get started with the first open question, where I'm gonna have the panelists actually tell you a little bit more about their expertise, the work they do in this space, and how they're advancing the healthcare workforce pipeline. So we'll start with Dr. Ulysses.
Thank you, Shyrea, and thanks to all of you for this important forum and for being here today, just 3 days after Mardi Gras.
Hello.
So again, my name is Dr. Ulysses Burley. I am the founder of UB The Cure, which is an organization that operates at the intersections of faith, health, and human rights, where we treat people and not just disease. I am an immunologist by primary training. I also have a master's in public health and cancer epidemiology. But for the better part of the last 10 years, I have done the work of health equity exclusively under the umbrella of UB The Cure. I'm also a member of the National Minority Quality Forum Advisory Board and a member of its inaugural 40 Under 40. Yeah. So my path to medicine was quite direct, but my path to where I am now was rather circuitous. I always knew that I wanted to be a physician. I knew that I wanted to help people. I was fortunate enough to grow up in an environment where I saw people who looked like me who were physicians. And so very early on, exposure was a great part of my understanding that it was something I could do, and it was something that I could be successful at. It wasn't until my mother passed away of breast cancer when I was 10 years old that I knew what kind of doctor I was going to be. I was going to be a cancer doctor. I wanted to help people like my mother so that little kids like myself and my sister didn't have to spend their childhoods in hospitals for caring and looking after their parents. And so I did everything I knew to do to start preparing for a career in medicine. I was fortunate enough to grow up in Houston, which features specialized high schools in the public education. And so we have a high school for performing arts, we have a high school for law enforcement, for criminal justice, aviation, engineering, but we also have a high school for health professions, Michael E. DeBakey. Of course, as somebody who knew he clearly wanted to be a doctor, I applied to go to DeBakey. And so my medical education started very early. And the curriculum at my high school included a clinical experience. And so my junior and senior years of high school, I would go to a hospital in the Texas Medical Center, which is the largest medical center in the world. And I had the privilege of shadowing doctors and surgeries and all different types of areas in allied healthcare. So my entrance into the healthcare pipeline started very early. And I know that because although it was a specialized school, it was a part of the public school system. You had to test to get into the school, but it didn't cost anything. And so as you all in the room who really have the power to change things, we start thinking about where some of our federal funds go. I think more public specialized trainings in K through 12 education has to be one of our priorities. Now, started very early, ended up going to Morehouse College and HBCU. I was accepted to Yale, but I was recruited by Morehouse. And I'm being clear about that because Morehouse came to my school for me, to look for me. And because of that, I went to an HBCU instead of a quote unquote Ivy League school because I felt like I was wanted from the very beginning of my experience. I went to Morehouse College on a Packard Scholarship, which is a scholarship specifically to train Black men in the sciences. And we had all kinds of requirements throughout my matriculation, one of which was that we were to do clinical or scientific research throughout the year and every summer that we were in undergraduate training. And so did that, ended up at Northwestern School of Medicine for 3 of those 4 summers while I was in college doing cancer research because that was still my track. And ended up going to Northwestern School of Medicine because of that exposure, right? So everything was really, really set up for me, if you will. But then I got into medical school and I started my training. Going to a majority school, I was one of 8 Black people in my med school class. I was in a new Midwestern city outside of the South for the first time in my life. And not only was I overburdened with work, but I was tired of being asked by campus security what I was doing on campus every time I went to access the building. And so that drove me to do a 1-year fellowship in South America, Buenos Aires, Argentina, right in the middle of my medical school education, where I was working with people living with HIV. And that experience changed my life. It changed my trajectory from one of cancer to one of immunology and HIV and AIDS specialization. But it was also what exposed me to the social determinants of health, the ways in which where we grow, where we work, where we live, where we worship, impact our overall health and wellness. But even more than that, I learned that racism and gender inequality and government corruption and substance misuse and violence, all of these things played into physical diagnoses for people, such that I understood that no matter what I did for people in a clinical setting, I was always sending them back out into a world that made them sick. And so I started to then think about how to treat the social ills that would then alleviate these medical and biological and physiological ills. And so under that premise, I founded You Be the Cure. Obviously, there's a lot in between then. I finished my medical training. I went on to do a fellowship in AI, and I would lead clinical trials for Black and Latinx communities around asthma because I was the only Black person in the AI department where I was. And so then my focus on community on patient-centered medicine, on advocacy, really increased, and it's what led to my pathway here today. But I really want to note the very early on exposure in a high school from a public education, my going to an HBCU and being cultivated throughout my entire education as a Black man who could be a successful Black doctor in this country. And then my experience in a Latinx country that exposed me to all of the ways in which social determinants impact our overall health really is what brings me to this space that I feel now. And along that way, my faith played an intricate role in all of the decisions that I made and all of the experiences that I have. And so that work is also integrated into my organization as well. And I look forward to talking more about how I and You Be the Cure are working to continue to create alternative pathways in healthcare for people who look like me. Thank you.
Thank you, Dr. Burley. That was an excellent way of, I think, illustrating the reaching people where they are and doing it earlier, right, to build that pipeline. So we're going to hear next from Dr. Cavalier. If you can tell us a little bit more about the work that you do and how you are playing a role in diversifying the healthcare workforce.
So good evening, everybody. My name is, again, Dr. Kanan Cavalier. I graduated from Warren Easton in 2014. I'm, again, born in New Orleans, raised here, and I attended Xavier as well. I graduated from their College of Pharmacy in 2020. Now I'm a inpatient operational pharmacist over at Ochsner Medical Center, which is the flagship hospital, a part of Ochsner Health, which is the biggest and largest health system in Louisiana currently. And as far as my community outreach, my biggest thing right now, since I graduated during COVID in 2020, my biggest thing has been informing people of what's actually going on, making sure they are getting correct information and knowing that in people my age, in social media, there's a lot of misinformation going on. Even in our communities, there's a lot of misinformation from us making up things from things that we just don't know and weren't exposed to.
Right.
So my biggest thing is just to be a leader, a mentor, and a teacher to literally anyone I see. And because I did not see people like myself growing up, so I am very pleased to be here. So thank you all.
Excellent. There's a strong theme from Xavier about reaching inwards and back into communities, so thank you. Dr. Sandoval, can you tell us a little bit more about your work?
Absolutely. So first, thank you for the invitation and the opportunity to allow Genentech to speak to the work that we're doing. I'm part of the Chief Diversity Office, especially the Patient Inclusion and Health Equity team. And we are, one of the focuses that our team has is how do we advance inclusive research across from early development of protocols all the way to commercialization. But the journey that took me, just listening to the journeys of my colleagues up here in the panel is, that the real idea of when we're thinking about workforce diversity, it starts with exposure, and I'm that perfect example of a perfect case as to what exposure can do. I grew up in a very small immigrant farm working town in California, in Southern California, in Ventura County. And up to this day, it's still almost 100%, I would say, immigrants from Mexico. I'm a Mexican American, first generation, coming from an immigrant family that has, no education. My parents, finished the first grade elementary and could just barely read and write. But what the idea is the exposure that you get at that K through 12 makes a huge difference. Having those mentors, having those teachers that really care to pull you through and say, this is what you could do, this is what the American dream is, right? But then having those opportunities when you get to college. I had the fortune of having a good education at a public school, and I went to undergrad at Berkeley, and was able to, again, be mentored. I was fortunate enough to be part of the Biology Scholars Program. And that's another way that, everyone who is here, I would suggest, look into programs that Congress can continue funding, especially in the STEM field. because I could tell you when I went to college, I was like, I'm going to become a biology high school teacher. That was my goal. And my counselor told me, no, there's more than just teaching, right? So I got exposure to research. Again, the theme here is exposure. Had the opportunity to do various programs, through the UC system at Berkeley. I was fortunate enough to, again, be mentored and was awarded a Howard Hughes Foundation undergraduate fellowship that allowed me to do research, be exposed to Alzheimer's disease. So I ended up getting a PhD in neuropharmacology from the University of Utah, focusing specifically in drug addiction and Parkinson's disease research. From there, I got the bug of going into industry, did a 2-year postdoctoral research program at Duke University, and then I got exposed again to the world of pharmaceuticals. And that was through a program that Procter & Gamble had that allowed academic postdoctoral fellows to apply for an industry program. Again, exposure. That allowed me to be exposed to medical affairs. That's where my medical affairs career started. And in addition to that, I was exposed to other areas within pharmaceuticals, including licensing. That led me to go to law school and have a degree in law. And actually, I practiced as a patent litigation attorney in a top litigation firm in California. And after all of that, combining the law and the science, I came back to my true calling of being a scientist, came back to the industry with Teva Pharmaceuticals and re-engaged back in what it is that I truly wanted to do. And I still think that all of us are growing up and we morph into what those exposures and experiences are. And that led me to be here today as being part of the Chief Diversity Office, very interested in learning how can we engage our communities, specifically being a Latina, understanding what it is that we need to do with our Latino community. I don't have to tell you the statistics. Latinos are the minority population that is growing the fastest in the US. Yet when we think about clinical trials, we only have at the most 1% to 5% representation. Again, why is that, right? So part of being part of the Chief Diversity Office and being really part of the external partnerships and building that for Genentech, it is a commitment that, I'm very proud to say we truly want to build that, not only with the Latino community, but as well with the Black community, Asian communities, to really understand what can we do, let's listen, and what everyone, even before this panel, was saying, how do we go where the patients are? Yeah. How do we build that trust? And really demystify and have bust all the myths that minority patients cannot and do not want to be part of clinical trials, because that's truly not the case. Right. So I'll stop there.
Excellent. Thank you so much for highlighting the industry point of view here. So we're going to actually head over to academia and hear a little bit more from Ms. Webster about her work right here on campus.
Okay, thank you, Shyrea. And thanks to Congresswoman Kelly, Brandon Garrett, and their respective teams for engaging me in this very important and necessary conversation. We at Xavier are very proud of our legacy of being a national leader among U.S. colleges in placing Black graduates into medical school and graduating Black medical doctors. We are very proud of that. However, there is still so much more work to be done. I appreciate your stats, Shy, about the rise in applicants for that 2021-2022 med school academic year, but that's a layered number. Just because you have an increase in applicants, that does not mean that more underrepresented students have been accepted into medical school, and that's problematic. But I'll get into that a little bit later. So again, I am Quavadis Webster, more commonly known as QV, and I serve as the director of the pre-med program here at Xavier, more specifically the advising that takes place within our pre-medical office. I am a New Orleans native and a two-time graduate of the university. Both my bachelor's and master's degrees were earned at this esteemed university. This is my 22nd, well, actually May will make my 22nd year of pre-health advising at the university. So it is truly a mission a ministry, a labor of love, because I know that my students belong in those spaces that they've tried so hard to keep us out of. So I'm very happy to be here with you today. In terms of how I see myself contributing to a more diverse healthcare workforce, I assist almost 1,700 pre-meds at Xavier, almost 1,700 students who are signed in with my office who indicated an interest in medical school, dental school, optometry, podiatry, veterinary, physician assistant, physical therapy, chiropractic, the gamut of health professions. We assist them, most of whom are Black and female, with the process of preparing competitive applications to health profession schools. And the word competitive is so important because anyone with a credit card can swipe and apply to medical school or another type of health profession school, but we need to make sure that our students are in a position to present those competitive credentials that allow them to gain acceptance into one or more programs. So we have very targeted initiatives in place at the university through my office, assisting our students with that process of preparing those competitive applications. And just for context, when we talk about pre-med, pre-health, that just indicates typically a student at the college level who is taking part in that process of preparing for application to some type of health profession school. That means taking the required courses, making sure that they're preparing adequately for whatever entrance exams are required. So for example, for medical school, students must take the medical college admission test or MCAT. Students are also at that pre-health level or should be at that pre-health level, gaining experiences that demonstrate an interest in the health professions. And so at Xavier, we have a very concerted effort to assist students with demystifying that process of applying to health profession schools, because frankly, if you don't have someone in your family or someone close to you to share with you the ins and outs of the dynamic process of applying to these health profession schools, then you're not privy to that information. So when our pre-med advising program started at the university in the 1970s under the direction of Dr. J.W. Carmichael, the great Dr. J.W. Carmichael, he said, you know what, these students need to know out of the gate what it takes to get into health profession schools. So we have a very structured and comprehensive, strategically planned system in place where we begin advising our students on the process of applying to health profession schools freshman year, and more specifically, the Friday before classes even start in August of freshman year. That's our very first of 16 freshman pre-med meetings, where we are front-loading those topics related to the process of applying to health profession schools. So there is no reason that a student who's actively engaged in our pre-med advising should not know what they should be doing and when to be competitive applicants to health profession schools. Now, some context on our program. It is twofold. The first part of our pre-med program is the academic side with the curriculum and instruction. The second part is the student support component. Several offices are included in that component, including my office, the pre-medical office. And again, we're in position in place to help those students put it all together and make sure that when junior year is completed, because students typically do apply that summer between junior and senior year, they are presenting them their best selves to these admissions committees. They are poised to be the competent and compassionate healthcare professionals who embody the mission of St. Catherine Drexel to create a more just and humane society. And that is how I see myself contributing to this very important work.
Thank you, and it was really interesting to hear more about the model that's being done here. I know it's something that has been upheld across the country and in other communities, so thank you. We're gonna head to Miss Molly Ryan on Zoom and learn a little bit more about her role in health workforce diversity. Molly?
Greetings, everybody. Good afternoon. Thank you so much for the opportunity to speak to you live from the great state of Maryland. I wish I was in Louisiana, and I hear that it was a great time during Mardi Gras, so I clearly missed something. As mentioned, my name is Molly Ryan. I am the Vice President of Government Affairs and Policy for Global Blood Therapeutics, GBT. We are a global organization, and I oversee government affairs for the United States, Africa, Latin America, Europe, and just really delighted to join you today. I think as I think about how we are impacting different policies, especially those that are related to the workforce. I would be remiss in not mentioning that the unfortunate murder of George Floyd was a catalyst to organizations, businesses, and policies rethinking their strategy and different policies to promote diversity, equity, and inclusion across entire enterprises. Organizations like mine at Global Blood Therapeutics were no different, but clearly we were ahead because this was always something that has been front and center for our CEO, Dr. Ted Love, who is an African American. We asked ourselves, what could we do differently to continue moving the agenda forward on equity? And as a result, we formed two councils. One is a social empowerment council comprised of leaders across different think tanks like the NAACP, Voto Latino, the National Black Church Initiative, and others. And two, because we're a company that is focused on blood disorders, starting with sickle cell disease, we also formed a second version of a council called the Sickle Cell Disease Healthcare Equity Council, comprised of national, state, and local leaders who are only focused on sickle cell disease. And as a result of these two significant councils and initiatives at Global Blood Therapeutics, we now have a pilot on sickle cell in Atlanta with NBCI, the National Black Church Initiative. And we are working with Congress to introduce a major piece of legacy legislation that would seamlessly coordinate care for individuals living with sickle cell disease from the time they are born all the way through adulthood. And the reason why I'm emphasizing legacy is because in the last 50 years, we have not seen any major piece of legislation that could really impact the lives of those living with sickle cell disease. The last version of legislation was when former President Nixon in 1972 urged Congress to do something on sickle cell disease. That was the last time, 50 years ago. And yet sickle cell disease was the first genetic disease in the entire world to be identified. We have come a long way, 100 years later, and we haven't had any other piece of major legacy legislation. We are tremendously proud of these initiatives because they're not only tangible, but they're making a difference in promoting equity, eliminating health disparities, but also creating solid funding to increase the workforce that is taking care of individuals living with sickle cell disease. I want to urge you, if you would like to get involved in this legacy piece of legislation, please feel free to reach out to me. I would also be remiss in not mentioning the role that the government is taking as it relates to workforce diversity, and applaud President Biden for upholding and reinstituting the executive order on diversity, equity, and inclusion and accessibility in the federal government. I mean, think about it, folks. The federal government is the largest employer in the entire country, and not having a mechanism to actually build an incredible workforce, that would be a miss. So I am just delighted that this was reinstituted and it affirmatively advances equity, civil rights, racial justice, and equal opportunity in the entire government. And to further advance equity within the federal government, this order that President Biden signed, it establishes a policy to cultivate a workforce that draws from the full diversity of the nation. Lastly, not only do I wear a hat at Global Blood Therapeutics, but I am also the president and co-founder of the Washington Heads of Office Leadership Council, which is a nonprofit organization comprised of senior leaders and executives of color who are in government affairs, who represent Fortune-level companies and trade organizations. The work we do underneath the Washington Heads of Office Leadership Council is not only to gather ourselves and share best practices, learn from each other, but it's also over the last 4 years, one of our primary goals was to groom the next generation of government affairs professionals and leaders. So please feel free to check us out at Washington Heads of Office Leadership Council, because every year we gather 10 individuals. We select 10 individuals that would like to be government affairs professionals, and we take them through a rigorous training of what it means to be a head of office or to lead a government affairs function. So with that, Shy, I'm going to yield back to you.
Thank you, Molly. That was an excellent example of how you're actually working to fill those gaps
And we're going to learn a little bit more from Ms. QV about how it's being done here on campus with addressing the gaps that still exist in academia, and then what role can academic settings play in kind of priming and building the pipeline.
Okay. Well, when Shy told me that, I would have this first question about the workforce pipeline, I decided to craft my own definition of what that pipeline means based on the work that I do. And so it is an intentional group of initiatives across both the education and career span, and this is aspirational, which should, number one, introduce and expose individuals to health careers. And we talked a lot about that importance at the K-12 level, and I'm going to reiterate that. It is so very important to expose young people to these careers very early on. Dr. Burley did DeBakey High, and I'm very familiar with it because we have a number of DeBakey High graduates who chose to come to Xavier.
Xavier was my second HBC.
Okay, I'll give you that. And so those type of pipeline programs that funnel students through the STEM education and career pathway are really important. So that introduction to the careers and exposure. If you've seen the documentary Black Men in White Coats by Dr. Dale Okorodudu, there were several gentlemen in that series who kept referring to this idea of you can't be what you can't see. And it's really important for us to realize that really does begin very, very early on. And so that introduction to the health careers and exposure is very important. The second thing I think the pipeline should be and should do is provide individuals with equitable tools that eliminate barriers to the health professions, because there are several barriers to the health professions, but also maximize success for individuals at the pre-professional level, once they're enrolled in professional school, and once they're in the profession itself. That's really important. When I talk about equitable, I mean really meeting people where they are and giving them the resources that they need to not just survive, but thrive. Somebody's always trying to give us the bare minimum. Just take that, that's enough. That's not gonna work. That's not going to work. The second thing it should do is be financial in nature, making sure that students are able to afford this. College is very expensive, but health profession school is way more expensive, okay? And so for some students who are already struggling to pay for college, four-year college, and knowing that they need that four-year college to go to that next step to health profession school, it's like I have to make a choice based on financial sense for me and my family. And so that is another barrier to the health professions, the cost that is associated with not just college, but also enrolling in professional school. And aside for the education component of that, in terms of these resources and barriers, just to apply to health profession schools is super expensive. You know, the medical school application process, just to apply to one medical school, I think it's $170. And each additional school you add on that application is about $42 currently. And we at Xavier encourage students to apply to at least 10 schools. And if you didn't already know, there are two types of medical schools in the US, schools of osteopathic medicine, which confer the DO degree, and schools of allopathic medicine, which confer the MD degree that most people are familiar with. And if they're gonna apply to both types, and we do recommend that they consider both types, that's 2 application services that students have to apply through. But even before they do that application, they have to take that medical college admissions test for medical school, the DAT for dental school, the OAT for optometry, et cetera. That test, or those tests, cost money too. I think the MCAT right now is $395. But before you take the test, you need test preparation. And those courses can run $2,500 plus. Now, we are lucky to have partnered with Kaplan, and we offer a discounted test prep for MCAT, DAT, OAT, and GRE to our students, but it's still not cheap. So these are all expenses piling up on top of each other that you're telling a young Black or brown student that they can do that, but they don't have the means to. Okay, so it's really important that any conversation, any legislation that is put forward, it includes that financial aspect, those resources that are definitely necessary. It should also include the recruitment, retention, career development, and career advancement piece, so that once our students are in these positions, they're not pegged to one place. They're able to advance within the realms of the health professions. That's really important. So we have introduce and expose individuals to the health careers, provide them with the equitable resources to eliminate those barriers. And thirdly, I would say the pipeline should nurture competent and compassionate health professionals who advance the cause of equitable health, particularly as it relates to Black and other underserved and marginalized communities. So that's my aspirational view of what that pipeline should look like, K through 12 throughout. It shouldn't stop once where, a student is in professional school or has that MD, DO, DDS, what have you. It should be across the span of both education and career. And the second part of the question was, why do we really need diversity in healthcare? So to take a stat from the AAMC, the Association of American Medical Colleges, in 2019, they reported that only 5% of active physicians in the US were Black, compared to about 14% of the US population being Black. And so it's long overdue. This is a public health crisis that we have such a lack of diversity, underrepresented minorities in the health professions. We know that the doctor-patient relationship is paramount to positive outcomes in healthcare, with trust laying the foundation for that collaborative relationship with the doctor and patient, where the patient really does have an active role in the future of his or her healthcare. So that's really important. But there are studies that suggest that when patients and physicians share the same race or ethnicity, that the patient tends to be more trusting. And therefore, if that person is more trusting, probably more susceptible and willing to take recommendations about medications, treatment, follow-up care, et cetera. That's really important. But this work is also very necessary because we need to vehemently reject that centuries-old false narrative that we don't belong in these spaces, that we're not worthy, that we're not capable. It's a lie. And at Xavier, which has been Wakanda before we knew about Wakanda, I see it every day. I see it every year when I receive announcements for residency placements, what they call the match for medical school. I see it with, even our students who maybe don't get into health profession school, but they found another way. I see it in those students as well. So it's really important. It's also important because I don't know how many of you know about Abraham Flexner's report on medical education in the US and Canada. Well, Mr. Flexner asserted in his report in 1910 that rather than train Black students as physicians, they should be trained as sanitarians to keep white people safe from disease. Abraham Flexner, also known as the father of modern medical education. His report also resulted in the closure of 5 of 7 historically Black medical schools that were in existence at the time, one of them being right here in New Orleans, Flint Goodrich Medical School. There was a study done that estimated that had those medical schools stayed open, from that time through 2019, there would be an additional 35,000 plus Black physicians. Okay, so for all of those reasons and many, many more, it's long overdue. So many more resources need to be put into increasing the diversity of our healthcare workforce. And like I said, I see it every day with the work that I do with the students at Xavier. There are thousands of Xavier health professionals who have walked these halls and are now doing great things out in the world. But we know there can be so many more, and not just at Xavier. It's sad that we have the stat that we have. Far more institutions need to be able to do the work that we're doing. And in terms of filling gaps and looking at what can be done in academia to help this, again, it goes back starting with K through 12, the exposure not only to the health career and STEM research careers, because it's not just health careers that we need people seated at the table. It's pharmacy, it's research, it's the gamut of the health industry that we need to be represented, but also looking to support initiatives for students at K through 12 with study skills, time management, ACT, SAT preparation, critical thinking. Those are the tools that students need to be successful at the college level, because if you're not successful at the college level, you are not being accepted into health profession schools. So making sure that initiatives are put in place at that level. At the college level, Xavier, for many, many decades, has had what is called the Summer Science Academy, a series of pre-college summer programs whereby students are introduced to different levels of science coursework before they would enter that coursework in high school. So there's Math Star before you take algebra, Bio Star before you take biology, Chem Star, and then there's a SOAR program. So Brandon Garrett and I actually met during those summer programs at Xavier, even though he too did not choose to attend Xavier University of Louisiana. We won't hold that against him. He is our board member, so we won't hold that against him. But we met in those programs where it brought students from all over, not only Louisiana, but the upper level programs brought students from outside of Louisiana together to do STEM. You know, the majority of whom were Black students. And so as a student who graduated from an all-girl Black Catholic high school in New Orleans, I was so excited to come to Xavier during the summers to meet people from other schools and see persons other than females during those summers. And it was a great experience to see like-minded students who were pursuing the same types of interests. And not only that, the fact that the groups were led and everything was managed by currently enrolled Xavier students in the sciences, pre-med students. So it's that type of engagement too that proved very worthwhile in that Summer Science Academy as well. The programs back then were funded by HHMI and HCOP. The programs are still in existence, but these are the types of things definitely that need to happen among many things at the K-12 level. Also at the college level, as a pre-health advisor, I talk to advisors from colleges all across the country who want to know what's the secret sauce at Xavier. How do we do what we do, especially with such limited resources? For perspective, there are only 3 full-time staff in my office, and I'm one of them. And as I mentioned, we are serving nearly 1,700 currently enrolled students and alumni who want to get our assistance with preparing for application to health profession schools. So it's a lot. But when they reach out to us, a common thing I'm hearing from advisors at other schools is we just don't have the staffing and resources to do this work. Typically, you have faculty members in biology or chemistry who are just thrust into the work of also doing pre-health advising. So they're being pulled in a variety of different directions, and it's hard to be able to focus the type of energy, time, and resources that one would need at the college level to do this type of work, especially if you have a large population of pre-health students. So, you know, understanding the importance of this work and putting the money where it belongs, including in college staffing. For the health profession schools, and people say I get on them a lot, but I do. I should. We're sending a lot of students to them, and we expect them to take care of our students, but they really do need to reevaluate admissions processes. There is such an over-reliance on that medical college admissions test when we talk about admission into med school. And I keep mentioning med school, even though we help students with other health careers, that's the majority of where we see our students having an interest in applying. But they have such an over-reliance. And every year, I have very qualified students who have great grades, who have awesome and robust experiences in healthcare and beyond, who would make phenomenal physicians, but who don't get in because they don't meet a magic number on a test. And that's very, very unfortunate. Talk about a barrier that continues to be a barrier for many, many underrepresented students. And something has to change with that. And I could say that we've seen the result of MCAT being taken out of the admissions process with our early assurance program with the University of Rochester School of Medicine in New York. Since 2009, we've been sending students through that program. They apply at the end of sophomore year and can gain a conditional acceptance into that medical school. And if they gain that conditional acceptance, the MCAT is not required. The last 2 years of their college experience is spent focusing on their coursework, taking additional courses that would help better that transition into medical school, and getting more experience, especially service experience, because that is something that's very important at the University of Rochester. We've sent 38 students to that program when the first students entered, since the first students entered in 2009, and our students have had no problem finishing the program. So the question becomes, how is it that University of Rochester can take our students in with all these stellar qualifications and no MCAT and still graduate them and place them in residency programs? The process needs to be reassessed, definitely. Also at the medical school level, more programming with the exposure, the summer enrichment and research opportunities that should be paid, because again, our students are in college and they have a lot of costs to contend with. And so at Xavier, we do encourage students to participate in at least one summer enrichment or research program before they actually apply to health profession school. And of course, students are going to be looking for programs that pay them well. Most of the programs that pay well are those that are focused on research. And so we tell students, apply to as many programs as you can. And if it ends up being a strictly research program, that's okay, because you still have a way before or after that program to do shadowing with physicians, to volunteer, however you can get the clinical exposure that these health profession schools want to see in addition to doing research. At the hospital level, these training programs, as well as professional organizations like the AMC, they need to put resources into making sure these types of programs are available to students as well. And then looking at health professionals, giving back, reaching back. Again, you can't be, or it's hard to be what you cannot see. And another takeaway from that Black Men in Medicine documentary was people's choices are 100% dependent on the choices around them. And so I think that speaks to the importance of that exposure in health professionals, especially underrepresented health professionals, speaking to that and giving life to the fact that this is realistic. And Flexner was dead wrong in what he said.
Excellent. That is a clear path on things that we can certainly consider for academia. We're going to head over to Dr. Burley and actually talk a little bit about innovation. I think oftentimes we may think of healthcare as one thing, but I know you mentioned allied health and your work with community health workers, so we'd love to hear your ideas around or recommendations for innovating in this space.
Yeah, certainly. First of all, remind me never to follow
Oh, please.
you.
Please, I'm basic.
Everything that she said, everything that she said. So first and foremost, I had options. I was fortunate enough to grow up in a middle-class Black family. My mother passed when I was really young. My mother was financially savvy. She left me and my sister's trust funds. That trust fund was supposed to be geared toward my education. That's what I used it for. As a result of that, I didn't have much debt when I finished medical school. And so that gave me a certain freedom to be able to pursue different avenues within the career. If I had had a six-figure medical school debt, I would be in a hospital right now. And I wouldn't be talking to you all because I would need to be able to pay back what I took out to be able to advance myself. So when we talk about allied health careers, you talked a lot about the barriers that are financial. We have to realize that when we're Black and brown communities are strapped with generational poverty, and because of generational poverty, we've been unable to build generational wealth. And so even if you have all of the access and the wherewithal and the aptitude to get through college and medical school and otherwise, you might not necessarily have the option to be able to endure a certain amount of debt because of your choices, right? Because of your situation around you. And so I often have colleagues to ask me, well, how do you do it? And you'd be surprised at how many people hate clinical medicine and would leave if they didn't have bills to pay. So they often ask me, how do you do it? How much money do you make? I'm trying to decide if this is entrepreneurship is something that's for me. But if we can remove that factor specifically for Black and brown communities, then I think we would start to see the increase that we need in terms of diversifying the workforce. So one of the ways in which I think we can innovate the workforce pipeline is by innovating current legislation that's already available to us. And so HR 40, which is the bill around the study and investigation of reparations. I spent a lot of time talking about reparations and about what reparations could look like. And one of the things that I like to present is this idea of medical reparations. First and foremost, free healthcare for all African descent people. period. But even more than that, free medical education for all who want to pursue it. And so if we take out the factor of cost for medical school and otherwise, then people don't have to make decisions based on their situation. And that also means innovating the residency program and pay. For those of you who don't know, majority of residents' salaries are paid by the federal government. It's a legacy of the establishment of Social Security and subsequently Medicare. And so those of you who are here in the room have the ability to make sure that doctors now who have just come out of training, who have to have additional training in order to be able to fully service the medical population, don't make just $50,000 a year.
Yes.
If I guess, most people in this room make more than $50,000 a year. And if you look at the trajectory of medical education, by the time you're in residency, you're likely probably in your late 20s or your late 30s, which is when people are trying to establish families, they're trying to purchase homes, they're trying to begin to pay into some level of retirement, plant roots, things of that nature. You can't do it. You can't do it, especially if you're experiencing advanced training where your medical training might not just be 3 years, but it might be 8 years, and even more than that, right? Sure, the payoff comes after that, but you have to get there first. I wonder what the statistics are for all of the people who matriculated through medical education, but didn't necessarily finish because they could not sustain financially. And so we have to innovate the access of medical education. I always say that the cure for cancer is probably somewhere in Section 8 housing. And it might die there because somebody didn't have exposure, somebody didn't have access to the health professions. And a big part of it is economic. And so as we continue to talk about and debate reparations, I want us to think about what reparations might look like. It might not just be cash payments, right? We want that too, but it might also be healthcare, or it might be free healthcare access or free medical education access for Black and brown people. That's first. Another way in which we can innovate healthcare is by putting more resources toward the study and alleviation of the social determinants of health. The COVID-19 pandemic is a bad thing, but a lot of good things have come as a result of the pandemic, one of which is the attention given to the social drivers of disease, right? We learned that you can make a vaccine that's 95% efficacious, but it's just science on a shelf if you can't actually get people to participate in it, right? And so then there needs to be a community level intervention that makes your medical and scientific interventions successful. As a result, legislation has been presented around the improvement of the social determinants of health. I think it's called Approving the Social Determinants of Health Act, I think. And that act specifically asks that the CDC contributes more resources to the study of those social drivers of disease. I'll give you a statistic. We know that only 20% of modifiable health outcomes are impacted in healthcare settings. That's hospitals, clinics, laboratories, otherwise. The other remaining 80% play out in community. And so where people live, what food they have access to, whether they have secure housing or not. And yet, the funding model suggests that all of our resources go toward that 20%, what we do in hospitals and clinics and otherwise, and very little of it goes to that 80%. And so we need to start innovating how it is that we do healthcare by making sure that we resource what happens in communities more. I'll give you an example. I work with an organization called the Southside Help Organization in Chicago. And the Southside Help Organization is a nonprofit, and they offer a number of different health services for largely Black and brown people on the south side of Chicago. One of those health services are these community navigators, and they're not community navigators in the traditional sense. These are people who have relationship capital in our urban and low-income epicenters, who know where to go find Joe and Jane Doe when they drop out of care. And that might be in a halfway house, it might be in a shelter, it might be in an alley. These people generally aren't formally educated. They're often people who themselves had experienced that at some point in life. But they know where to go find the people who need care the most. They know how to engage them and they know how to get them back in care. It becomes especially important in the work that I do around HIV and AIDS, where we talk about the HIV care continuum, where you get people into treatment, but then you have to keep them in the treatment all the way through viral suppression, right? And so many people drop out after treatment, engagement of treatment. And so you have these community navigators, if you will, who know how to go find so-and-so, who hasn't been to their appointment, or who have missed their last few appointments, things that doctors and assistants and nurses otherwise don't have the capacity to do. But we have to start prioritizing those types of positions if we want to be successful in diversifying the healthcare workforce, but also the general population's health, right, which include Black and brown people. Furthermore, there also has to be an acknowledgement around the belief systems that play into how it is that people engage healthcare systems and how it is that they attend to their own health. I mentioned that faith is a huge aspect of the work that I do. I currently serve as the director of the HIV Vaccine Trials Network Faith Initiative, which is a significant investment by the National Institutes of Allergy and Infectious Diseases. I'll talk more about why that's important later. But you might wonder, well, what does faith have to do with aid, diversity, and health and healthcare, or otherwise? Well, I'll tell you what. Pew Research estimates that Black people in this country are the most religious people in this country in terms of how we worship, when we worship, our interpretation of sacred texts as being literal, and the amounts of times that we engage a faith space throughout the week. That becomes important when you're trying to get Black people to take a COVID-19 vaccine, right? Who say that it goes maybe against their faith belief or their religion or what they believe in. It also becomes important when people are more comfortable at a church or a mosque or a temple or a synagogue than they are in a healthcare setting because they've been traumatized in a healthcare setting. And so then churches become mass vaccination sites instead of a hospital or a health clinic or otherwise. And so then it becomes important to understand that and how belief systems impact the ways in which people engage their health, considering that the tenets of most faiths are rooted in health and healing, right? And so now we have to think about how do we fund faith institutions where outside of our country, majority of healthcare is delivered by faith institutions, by Christian hospitals, by Catholic charities, otherwise. And how that then plays into the way in which people interpret healthcare. QV, you talked a lot about the importance of the relationship between provider and patient, specifically culturally and racially and ethnically. You know, we always talk about cultural competency, but cultural competency isn't enough. Cultural competency is an understanding of one's culture, but what we need is cultural humility, which is an appreciation for one's culture, right? And it's really hard to appreciate one's culture that you've never experienced. And so how do you meet cultural humility? Well, you enlist more people of the culture in healthcare. We know from work from people like medical ethicist Harriet Washington, who in her seminal work, Medical Apartheid, noted that when Black women have Black OBGYNs, that their maternal mortality and morbidity decreases, and that the health outcomes of them and their babies increase. We know that. It's a key centerpiece of the Mamas Act that's championed by Representative Kelly. Thank you for that. And it's something that is irrespective of socioeconomic status. We know that the greatest tennis player that ever walked the face of the earth, Serena Williams, a Black woman, had to advocate for her own health when delivering her baby. With all the resources that she has, with all of the visibility and the notoriety that she has. And a part of the way in which we fix that is by making sure that we have more people who look like the people who we want to serve in those positions, because we know that they improve health outcomes. And so then we have to have a deeper conversation about racism and how racism manifests in all of our systems, including healthcare, and then how that trickles down. I currently sit on the Advocate Aurora Healthcare Board of Directors of Illinois. Advocate Aurora is one half of, Advocate is one half of Advocate Aurora Healthcare of Illinois and Wisconsin, which is the 10th largest integrated health system in the country. And when I was being interviewed for this board position, I challenged the leadership on the lack of diversity that I saw in the top tiers of the hospital system. And their response was that many of the people who were in those positions were legacy folks who had been in those positions for 20 and 30 years, which I understood. And so they couldn't necessarily diversify positions that people don't leave, right? So that's fair enough. But my purpose on that board, and I guess the reason why I was voted to the board successfully, is to hold healthcare systems from the top accountable, all the way down, right? I've been in the patient room before, and part of the reason why I left clinical medicine was because I spent more time doing bureaucracy and red tape and paperwork than I did actually helping patients. I spent maybe 8 minutes on average with the person. And the rest of my day was fighting with insurance companies and IRB and otherwise. And it wasn't life-giving to me, and I didn't feel like it was life-giving to patients either. And so now I sit on the board of a major hospital system to make sure that the policies that we put in place are life-giving. And so when we talk about healthcare professions, right? And it's not enough to just be a doctor, a Black doctor, but you have to also be a Black hospitalist, right? And you have to sit on these boards of directors, because you get in those rooms and you realize, oh, this is where the strings are pulled. And physicians and otherwise have very little power or say-so in how things play out. Largely, we integrate into a system that doesn't work so well for us, but it's the one that exists. And because we're already over capacity, we don't have the capacity to fight it. And so we need people who do have that capacity to be able to innovate, if you will, the ways in which we do healthcare as it stands. And so a lot needs to change. It starts with policy, right? It starts with the expansion of Medicaid, which majority of Black people in this country use as their primary health care, right? It starts with the expansion of access to health careers in general for people, and not just doctors and nurses, but medical assistants. An innovative program also out of Chicago, Christian Community Health Center, which I'm sure Congresswoman Kelly, you're familiar with. They serve the south suburbs in Chicago, and they have intentionally partnered with the National Institute of Medical Assistants to accelerate the training program for medical assistants, especially after COVID-19, when the healthcare workforce has significantly decreased because of fatigue and otherwise. Christian Community Health Center is a federally qualified health center. And so 90% or more of their clientele are federal insurance, Black and brown people. And so now they have partnered with a national institution to innovate the training process for medical assistants to where the first half of their training is online, virtual, which is the coursework. Right. And then the second half of the training can happen in their federally qualified health center to where they are hands-on dealing with the issues of the community right in front of them. And all of that can happen within 8 months. 8 months. And so now they not only are meeting a need that was already necessary, but it was even more exacerbated by the COVID-19 pandemic. But they're also training the very people who would come to that clinic for healthcare to then be able to service the very same community. And now we've wrapped in cultural competency, humility, all into that. We've created jobs, but we've also created access for people who otherwise wouldn't have access to it. And so, you know, this really isn't hard work. You know, as QV mentioned, we have less HBCU medical schools now than we did in 1850. She talked about the Flexner Report and the closure of 5 of the 7, but there were at least 13 medical schools that existed before 1900s. And since 2000, we've opened at least 30 more medical schools in this country, and not one of them have been at HBCUs. You'd say, well, why do they have to be at HBCUs? 30 new medical schools means that some of those schools are welcoming and training Black physicians, and that's true, but you have to know that 70% of all Black physicians in this country are products of HBCUs. And you also have to know that HBCUs specifically overwhelmingly give access to low-income and underrepresented communities where majority institutions do not, medical schools included. And so, we've seen historic investment in HBCUs over the last few years in terms of policy, omnibus bills and otherwise. The Biden-Harris administration has made a significant commitment in the fiscal year budget of 2022 for HBCUs, and that's great. But we also need an extended commitment to establish more HBCU medical schools, right? To create more. There's no reason why we only have 4 institutions. And, you know, even, you know, Drew, the 4th, you know, half of that partnership is with UCLA, which is a great thing, but, you know, it's still just a fraction of what we can do. And so, you know, as we're thinking about legislation and policy for all of you, and we talk about investing in HBCUs, let's think bigger than that. Let's get back to the 13 HBCU medical schools that existed, you know, more than 100 years ago, because as QV mentioned, the output then would be significant, and it would make America great. You know, we always talking about making America great, you know. Can't make America great without making Black America great, right? You can't make America healthy without making Black America healthy, or Latino America healthy. And so these are the ways that we can do that together. We just have to have the will to do it. And all of you, I know, have the power to do it. Let's get it done.
Excellent, yeah, collaborative action. I know Molly has a hard stop, and we started a little bit later, so I'm gonna head over to Molly to actually share with us who else do we need at this table to advance policy moving forward. Before you go, Molly, if you can let us know, who are we missing from this table?
I think you have an incredible panel. And first and foremost, QV, I think I want to sign up for the Wakanda University. That was just real right there. I might be a little bit on the older demographic to sign up for college, but I want to sign up. But I believe we have the right stakeholders that are gathered here today. You heard from policymakers, you had from community leaders, we heard from schools and what universities are doing to really improve this diversity in the workforce. You heard from industry, myself. We're working in the background, really trying to advance. I think we had the right team assembled for this conference. We need to keep the conversation going. We need the support of everybody to continue this discussion, to be a change maker, to raise your hand and volunteer for all these incredible initiatives and programs that you're hearing about, because it's not just enough to be in the space you're in, it is enough for you to raise your hand and do more. And yes, we ask ourselves, what can we be doing? What could we be doing more? There is so much more to be done. And we are just at the precipice of how we need to advance, especially as it relates to a diverse workforce. workforce, not only in the healthcare industry, but across the entire United States. So I thank you all so much for including me to be part of this incredible panel, and all the very best to all the listeners.
Thank you, Molly. That was excellent. And we're going to head over to Dr. Sandoval to hear what industry can do to that end as well.
Yes, no, thank you, Molly, for ending your segment there, because it gives me a nice segue as to what I need to talk about it as far as the industry role. As an industry, and you heard from a representative from Biogen earlier in the session, everyone is talking, everyone knows that we have inequities. We know that they're very embedded in our society. It's going to take a holistic approach from all of us to really commit to making a change, to come up with innovative ways. And from an industry, it's like, let's think of new ways that we're truly embedding D&I into all of the business decisions that we do. At Genentech, what we committed to when we made this public, we have 2025 D&I commitments. And these, talk about fostering belonging, looking internally at our employees, at advancing inclusive research and health equity, and transforming society. And that transforming society pillar is what makes, perfect segue into what we're talking about, work, diversifying the workforce. Because we know that we need to partner with our local communities. We need to invest in STEM education. And as an industry, we also need to provide opportunities for underrepresented students in order, again, exposure as to what they can do. You've heard a lot about medical schools and training medical doctors, but when we're talking about diversifying the workforce, it's more than only the healthcare provider. It's the pharmacist, it's the study coordinators, it's the patient navigators, everyone who is touching that patient, that we really need to make a difference. So my challenge to the legislators here is, think about how can you bring in industry partners, how can you bring in your actual healthcare worker force to understand where are those opportunities, and where can we help you frame and shape those policies that are truly going to deliver. What are we doing as far as at Genentech? And these are examples that maybe you could use, and we could continue the conversation, because conversing in forums like this, I think it's important to shine the light and say, what else can we do? K through 12 has been a big topic that all of us have touched. Genentech has actually spent over $32 million since 2015 with South San Francisco Unified School District, because that's in the backyard of where Genentech is located. And we've actually have what we call the Future Lab. And this is where Genentech invests not only in helping educators know how to teach science, because it's at those informative years. Kindergarten, get them early, right? Because you really want to spark those interests in what is science. Can I see myself as a scientist? We actually have our scientists and go and just donate their hours. It's over 65,000 hours that our employees have donated their times. Again, so people and the students can see there is someone that looks like me who is actually doing science. There is a woman scientist, a data analyst, health economics, exposure to all the different areas within drug development. And when we look at overall the program, to date, we, every year we touch over 9,000 students from K through 12. And 88% of the students who have been part of this Future Lab, at the end they come and say, I'm interested in pursuing a STEM career. That's what we want, because that's what it's going to take. Yeah. Other programs, in 2020, we talked about HBCUs. Genentech actually partnered with Howard University Regulatory Policy Program and the FDA. We came up with a 2-year fellowship program where we actually bring Howard University students to Genentech, and again, exposure. Yeah. What does a drug development program look like? And this is not only, talking from the bench, but regulatory, commercialization. So you could really understand that lens. Last year, 2021, and again, through a pandemic, right? There are opportunities. Genentech engaged with the San Francisco State University in trying to develop a unique undergraduate program that actually gives undergraduate certificates for data science and machine learning in biotechnology. Why? Because we know, and we heard it earlier from Gary, data matters, data collection. So these are programs that are very innovative, right? So industry comes, and it could be, these are just examples from Genentech, but I'm sure if you talk to other industry partners, there's many programs that are happening, right? But the reason, one of the things is conversations, partnerships. How can we make all of these patients, and not just the patients, but have that pipeline from the kindergarten through the 12 and beyond, right? Because mentorship is important, and it's mentoring that journey of that career development that is truly going to shape the diversity of workforce in our country. So back to you, Shay.
Excellent. Well, we're going to get ready to open up for questions. So if you have them, feel free to make your way to the mic. And while we get ready for questions, if you're also online, you can submit them. I can see them in the chat. Dr. Cavalier, can you tell us a little bit about, I know you're just getting into the workforce, but in preparation, you had shared some excellent insights about some of those barriers and what can be improved so that we can actually move forward in advancing some of these innovations. So if you do have a question, feel free to come to the mic as Dr. Cavalier talks about what can be improved.
Well, first and foremost, I do want to thank you all, and just want to say thank you for everything you're doing right now for people that look like me, for people that are growing at Xavier right now, people that have just graduated and started their career. Thank you so much, and I really appreciate being
Thank
here.
you, good sir.
But honestly, again, y'all all talked about such great topics that I thought I was going to speak on, but
And you still need to speak on
yeah,
it.
I do. I think I really want to talk about first is how the pipeline drove me to where I am right now, sitting here speaking to you guys. Again, I was in high school at Warren Easton, which is around the corner on Canal Street, and is a public high school, and I was also educated at a public elementary school in New Orleans, and raised by a single mother. So I want to just, again, be an example to all the young kids in New Orleans and elsewhere that people like me are not an anomaly, and that we are the new standard because of people like this, because of people like me. Again, I've just made it to the start and not the finish line by starting at Ochsner and getting my degree. And what was the question?
I know that you had shared a little bit more about how if you didn't have the opportunity when you actually interviewed, they traditionally look for residency. And this was an opportunity where you were able to go into the field that you otherwise wouldn't have been given an opportunity to. So we wanted to hear a little bit more about that example around getting the pipeline and in less traditional ways and making opportunities for diverse students.
Again, back to the pipeline. So in high school, I actually got here because some Xavier pharmacists came to talk to us in my medical terminology class. And again, that exposure is so important because I did want to be a surgeon, even though I didn't know any growing up. But for some reason, I really did want to be a surgeon. But again, that exposure, because there's so many different things in pharmacy that I know now that I wish I would have known before I went into anything. And I still love pharmacy, and I love this first year of practicing. So eventually, again, matriculating through Xavier, I had a rotational experience at Ochsner, and I was set up with my current manager. She was my preceptor at the time. And after we graduated, we reconvened, and I was like, again, you know what's going on in the world right now. Yes, I don't have a residency, but she was like, we would still love to have you, and we are going to take a chance on you. And I think that's the biggest thing as well, just being creative and innovative in our thinking and knowing that we do not have to stick with the traditional paths or do what we have always done.
Right.
And again, even going through my career now, I just try to think, what's new that hasn't been thought about? What can we do that was previously seemed impossible? How can we even halfway get there, even if we don't reach the full extent right now? So again, 6 months into my career as a new grad, and again, a new operational pharmacist at Ochsner, during my meeting with my supervisor, he said, like, now we will be more open to hiring new grads because of what you've done, because of the experiences that you've shown us that it can be done. You just have to want to do it. It's not about who's best, it's about who wants it the most.
Excellent. So changing the paradigm and reaching people where they live, work, play, and pray, certainly. It looks like, is it Congresswoman Kelly, you have a question for us? Earlier, she was leading on HVAC, now she's got questions. I love it.
I feel a little funny asking this question in a school like this, but in Congress, especially with the CBC, we talk a lot about HBCUs, a lot. I didn't go to a HBCU.
Neither did I.
And there's a certain amount of African-American students and brown students that don't go. And I just want to encourage people, don't forget about us. Because when I went before y'all were born, I went to school, the black I went to Bradley University in Peoria, and when I went to school, that was right after Say It Loud, I'm Black and I'm Proud, and, all of that, so we had the love, for each other, but when I graduated from that school, I wasn't gonna give it another dime, I wasn't gonna think about it because of the way we were treated. Now, I'm not gonna tell you, I went back to the school and worked, got my master's, was a director of Minority Student Services, so I helped a lot of the Black students. I started a mentoring program, and so Black alums mentored Black kids. I started a Big Brother, Big Sister, so when freshmen came in, they had a senior looking out for them. I started an endowment and a Black Alumni Scholarship that are 20-something years old now, but also I feel like sometimes there's a little, like you think, oh, you go to that school, you're okay, and Black kids need the mentoring. They need the companies to come and sort them out on the majority campuses also. And even now at Bradley, I'm on the Board of Trustees. So I've done everything at that school. And luckily, there's like 7 Black alums on the Board of Trustees now. So for the first time, we have a diversity, equity, and inclusion. We just got one. Vice president, he reports right to the president. But just some ideas about what can people do for Black students that don't go to HBCUs, I guess.
Exactly. You talk about reaching people where they are. We have to do it also not on HBCU campuses. I think to that point, in my experience, I actually was honored to serve as an AHEC, Area Health Education Center executive director, where they actually work with state and health and medical schools, and it's a federally funded through HEAA program. And it was from all this research we've heard about, having clinicians and the outcomes based on having clinicians and healthcare professionals that look like you. But in my work, I actually was in Massachusetts, right where I'm from, a little brown girl from Lowell, and working with my former member of Congress to get young, diverse nurses and students into the pipeline, and then had the chance to see it unfold in DC, Maryland, and Virginia. And to your point, if we're not working with those institutions, we're not going to be able to tackle that issue where you shouldn't have to just go to a provider that looks like you to get culturally attuned care. And that's what patient-centric care really looks like. And making sure that, as we talked about earlier in other panels, bringing in those perspectives and bringing our colleagues together, that's the only way we can do it, right? If we're only on the HBCU campus and we're not talking to the other institutions, we're not going to collectively address this. So I completely agree. No QV.
Right.
Can I just make a comment?
Oh, please.
And that is why, at the very beginning I mentioned, even at Berkeley, Biology Scholars Program, what can legislators do, right? That program is majorly funded by the Howard Seuss Foundation, right? But how can you take a model like that across the US? Because it takes, people who are committed to underrepresented minorities to really bring them up. Because you have to create an environment, it doesn't matter what college or university you are in, It is what can you create and what are the resources in order, because it's not enough to get the students in. The question is, how can we retain them? How can we maintain that career trajectory? Because even if you were to be accepted to medical school, but you're in there and there's someone that tells you you can do it, that's going to make a difference. And this is not just an issue in healthcare. Having the, wearing the hat of being a law student, it's an issue in law school. It's an issue that firms face. How do we bring talent? Because your customers that you're serving are not all white, right? It's a global economy, and that is something that we all have to think. And if COVID taught us anything, is the world is not that big.
Excellent. So there's another question. Thank you.
Yes, hi. I had a question about the role of artificial intelligence in diversifying the workforce. We talk about that I just went through the medical school admissions process. That's a role. People get screened out very quickly because of that. I know people who apply to biotech jobs like at Genentech who get screened out very quickly, people of color like my peers who are very talented, but they don't even get an interview. So we talk about we want to diversify, but then there are other barriers that are continuously put up in these different application processes that don't allow us to get there.
That's excellent. Anyone?
I'm going to tackle that, and then
Yes,
I'll open it.
please.
That is something that even within Genentech, I could just speak to Genentech, and I welcome other colleagues from industry to come to the microphone and also provide your perspectives. One of the things that we're really doing with this transforming society is exactly what you're asking. The question that you're asking is, how do we make sure that we build talent pools within Genentech and within our human resources? Now we're not calling it human resources, we're calling it people and talent, right? So we're really trying to partner with SACNAS, the Society for Advancement Chicano and Native Americans in Science, partnering with the Hispanic Scholarship Foundation, with the Gates Millennium Foundation, where they're actually touching the underrepresented talent, in helping us bring those resumes up that we're actually, and that's part of my job being at the Chief Diversity Office, is how can I bring that talent and channel it to the right people? Because we want to figure out how to make sure that artificial intelligence, or whatever parameters or platforms that we're using, that we're actually reducing those barriers instead of creating them, right?
And I'd like to share Dr. Conrad Tucker. He's a leader in this space, and if you're looking for resources, he's a brother that's been doing a great deal of research that's now at Cornell, where they have an institute tackling this in the healthcare space. And they modeled it in breast cancer and have been applying it, and they are looking at a number of ways to actually work through that stigma and those barriers. So that's a resource. And if you're on Zoom and couldn't hear Congresswoman Robin Kelly pointed out that she has 4 white papers on AI intelligence, on bias, privacy, and national security. Former Chief of Staff Brandon, thank you so much. This will be our last question because I think the panelists for the next panel is here.
I'll make this really quick. I just wanted to lift up a federal program that helps diversify residency programs, the Teaching Health Center Graduate Medical Education Program. It trains physicians in community-based settings. So physicians, well, those who are in residence are being trained in community health centers and other outpatient settings. It attracts those professionals who are from vulnerable communities. So they have programs on Native American communities. They attract those that are in some cases first-time residents and medical students. It's a very small budget, but just wanted to lift that up as a really important federally funded program that helps. That's a best practice and something that should be increased.
Yes.
Of course, also National Health Service Corps that attracts people to these communities. And I think one important point too, and again, I'm Sonia with Nova Nordis, but in my former life, I worked for the American Academy of Family Physicians. So this is a really important program for them. But just something that, but the beauty of these programs is just that they attract people to underserved communities, rural communities, and they tend to stay there. Because that's also a really important point of, both the training, but also retaining professionals in these communities and avoiding burnout and having connections, lots of different, elements to the pie, but nonetheless, very important program, very small budget, definitely worth supporting. And I'd say for those in industry that want places to support, there are programs across the country that can be supported. And one really sad story is that in Tennessee, their program closed. So the residents end up having to move to Alabama to finish the residency program. So the needs are there, and there are lots of programs across the country that want to create new programs in community health centers in underserved communities.
They certainly are a lifeline. Well, thank you to the leadership of Congresswoman Kelly and the Tri-Caucus members for continuing to make those programs available. Thank you to the panel for sharing their perspectives on building this pipeline, and for all of you joining us today. We're excited to hear the next panel.
And Garrett. I work at the National Minority Equality Forum. I am the COO. I am former Chief of Staff to the woman to my left, Congresswoman Robin Kelly, who has been the chair of the Congressional Black Caucus Health Braintrust since 2015. I also had the opportunity to work and be seated with my hometown representative, Congressman Carter, who is also from here, a native of New Orleans and a graduate of this very institution. And we are also very pleased to welcome Congressman Costa, as he just made sure I got his name right, a native of Fresno, California, a third-generation farmer, and one who's going to focus on rural health inequities. And so without further ado, let's just go ahead and give them a quick welcome. And my hand. And then I just want to start the panel off just asking each panelist what brought them here today. And I'll start with my forever boss, Congresswoman Kelly.
Well, my staff made me come, that was one thing. No, as you said, I'm chair of the I'm chair of the Health Brain Trust, but also I'm co-chair and co-founder of the Caucus on Black Women and Girls, and I'm also vice chair of Energy and Commerce, so a heavy health portfolio. And since taking over the Brain Trust, I didn't even know, I've learned so much about healthcare inequities, and really, that's why I'm here. The things I work on: maternal mortality, gun violence is a public health crisis, and affects Black and Brown communities more, and clinical trials. We have legislation around because of the racial inequities or disparities. So I'm all things health, and that's why I'm here. And want to thank all the panels before us, because we've learned a lot today, and we definitely have our marching orders. And hopefully, when we can get the right people at the table, that we can get all these things voted on and passed, so that we can have a healthier America.
The Congressman from California, what brought you here all the way out to New Orleans today?
I couldn't wait to get on that 5:30 flight this morning. Because of my friend, Dr. Robin Kelly. I was honored to be invited to participate with our I guess, almost newest member, Congressman Carter. I was just checking with him to determine his longevity in Congress, and he says it's all of 8 months, I guess. So, but this panel is so important to all of us: health, equity, and accountability, and I'm glad that this worked out. I am in my 18th year in Congress, and I represent a part of California that some of you may not be familiar with, the San Joaquin Valley. I always tell folks in Washington when they're a bit confused and bemused about what's going on in California, both the good, the bad, and the ugly. We use movie titles to describe what's occurring in California sometimes. I do. I said, well, you put California on the East Coast, it stretched from Boston in the north to Charleston in the south. And they look at me and go, well, that's a bunch of states. I go, bingo. California could be 6 different states with 40 million people. But the part that I represent is the large agricultural area in the San Joaquin Valley. It's between San Francisco and Los Angeles geographically, and it's inland. And we have all the health challenges in terms of equity and access that I really am very focused on. I've been spending a number of years, and I'm working with my colleagues here, the Tri-Caucus, member of the Hispanic Caucus, as well, many of us belong to a lot of caucuses, but I'm also a New Dem and a Blue Dog, but access to rural health care is something that I was involved when I was in Sacramento in the state legislature, and we're trying to get a medical school. And I hope this horrific pandemic that we've all been through has taught us a few lessons in the last 2 years. I sure hope so. And of course, we're not out of the woods here yet with almost 1 million people that have lost their lives, Americans. But one lesson I've learned is that if you have a shortage of personal protective equipment, you can turn that around in a month or a couple months. But if you have a shortage of physicians or nurses or other healthcare workers, and these are the unsung heroes and heroines in my book for the last 2 years who have risked their lives and at risk to their families, that have gone to the hospitals, the nursing homes, the care centers, the clinics every day in the middle of this pandemic. We have a shortage of physicians in my region, as we have in other parts of the country. I'm trying to get a medical school. We have a shortage of nurses. We have a couple of nursing schools, but we need to plus that up. And working with my colleagues here in the Build Back Better, we had $1 billion efforts to plus up existing medical schools and nursing schools, like the one here at Xavier. And now we're trying to figure out where we're going to get that funding. In my area, as opposed to other places in California, we have half the physicians per 1,000 people. There's 2.2 in California per 1,000 people. In my area, it's 0.9. So I'm here because of my friends, and this is such a critical subject for all of us. Thank you.
And my fraternity brother?
And I'm here because Robin told me to be here.
That's good motivation.
I am obviously honored to be here, to have you all here, to have my esteemed colleagues here. Dr. Kelly, the great Congresswoman who has been a great friend and advocate for everything health, and so many other very important issues in the Congress, and my esteemed colleague, Congressman Costa, for being here. So thank you guys for coming to Louisiana to be here at my alma mater, a school that I am incredibly proud of and could not be more proud of the young people that were represented today, that sat at this very stage, and some may still be in the audience, and many more that are listening, who have really created a path for themselves while carrying the Xavier University banner along with them. You heard them say, and I will reiterate, this is much more than just a university. It's much more than a place of higher learning. It's much more than just a place where academics are held at the highest level. It's a family. It's an environment that is built to create the kind of success that you see with these very impressive young people who sat at this table and made our hearts swell with their ability to articulate the experiences that they've gone through and their ability to talk about what needs to be done to create the kind of equity that's missing in this particular area. Health outcomes, health education, opportunities for medical schools, opportunities for greater inclusion at the policy level, to talk about the outcomes that we find ourselves faced with. We know that COVID turned a light on and showed us some disparities that many of us always knew existed. Right. But it turned the light on so the rest of the world's able to see it as well. The kind of injustices that we see in communities of Black and Brown that continue to be pervasive. But good thing is, we've got a Xavier University We've got so many other strong HBCUs. We've got caring members of the United States Congress that are assembled here with me today who fight year in, year out, day in, day out to come up with not just listening ears, but working hearts, to come up with solutions, to provide resources. And so this panel discussion is yet another one of those examples to bring it home, to listen, to talk, to have an exchange, to have corporate America that's represented as well, to be here, to be a part of the discussion. Our corporate titans who are represented in the audience and beyond, to listen and to know that you have an opportunity to harvest some of the best minds, some of the best brains, some of the best trained, but you got to create the opportunity and recognize the value. And these discussions help us do that. And I'm especially honored that Brandon and his team chose to be here, to come home, to be a part of the discussion here in Louisiana. And I can't thank my dear colleague, Congresswoman, for being such an incredible friend, an incredible leader, and being here particularly under challenging issues of herself, running things at home and issues with their own districts, but they're here with us today. And we should give them a round of applause for that.
Thank you.
And because we knew you were coming, we ordered up some of the absolute best weather we can find.
You did.
Thank you.
It's terrific.
Yeah, and we
Just like
appreciate
California.
we appreciate the hospitality, sir. And I just want to follow up with you, since we are in not only your home, your alma mater, your neighborhood, your school. What are some things that you noticed growing up, some health inequities that you noticed growing up right here in the 2nd Congressional District? And what are some things that you're doing or plan to do in Congress to deal with them?
Well, much of the health inequities that I found growing up, unfortunately, are still present today. And they haven't changed a whole lot. And sad to say that they're not very different from my district or any other district that has a strong concentration of Black and brown people that historically have not had access to health care, have not had access to preventive health care, have not had access to healthy diets, have access to even understanding the significance of it, or even if you could, having the ability to pay for it. A cheeseburger will cost you 99 cents, but a salad will cost you $6. Shopping at your local grocery store is going to cost you X. Shopping at a Fresh Market or Whole Food is going to cost you 4X. I mean, it's pretty basic. And so in my community, we see, and we saw growing up, and we see today, you drive through the neighborhood and you see a young man, a young woman, dragging half of their body with them because they're a victim of a stroke, because they've had unchecked, unbalanced diabetes, high blood pressure, which causes all those other onsets when it goes unchecked. No access to health care. You talk to the average African-American male and ask them, when do they visit a doctor? Well, if you don't have health insurance, you only go to the doctor when you broke an arm or cut your foot or had an emergency. And you did that through emergency room. It wasn't even urgent cares. You went to Charity Hospital and you sat in that room for hours and hours and hours and hours until you finally got your number called. So preventive health care was not even thought of. So you literally rolled the dice every day with your life and prayed that nothing happened. And when you did, you ended up, as many of us did, at Charity Hospital, the beloved Charity Hospital that so many of us were born in, so many of us were cared for in, so many of us had to go when we had any issue whatsoever, because oftentimes there was no access to health care other than well baby visits to get a vaccination. But then that period from being an infant to adult, it was rolling the dice. And we see what happens as a result of that. We see the unhealthy outcomes. We see the maternal outcomes with fatalities during birthing. When I was a member of the Senate, one of the last things I did in the last couple of years I was there was to help fund studies to determine why do we have these maternal outcomes? Why are Black and brown women dying during birthing at an alarming rate greater than their counterparts? In this very city, Dr. G, who was the Secretary of Department of Health and Hospitals at the time for Louisiana, had a seminar much like this, where we had noted professionals to come from all over the world to talk about problems, solutions. Shortly, right around that same time, I think it may have even preempted a little bit of the momnibus that was going on in Congress, or maybe around the same time, but to do the exact same thing, but on a larger scale, to come up with solutions, to talk about how do we make these things better. So the things that I saw growing up, unfortunately, really haven't changed a whole lot. All the things that I mentioned, they've gotten better. We've had the passage of Obamacare, which was incredibly powerful for people. My governor, John Bell Edwards, when he took office 6-7 years ago now, the first thing he signed was the expansion of Medicaid that allowed, Medicare that will allow people to instantly gain access when our previous governor, Bobby Jindal, declined, like many other governors, because it was something Democrats were pushing. And we've got to get beyond partisanship when we talk about a lot of things, most things, but certainly when we talk about healthcare. That's not a partisan thing. There's many sick, poor white folk as there are sick, poor Black folk. There's many sick, poor Democrats as there are sick, poor Republicans, Latinas, Asian, and other. There's some things that clearly just should not be political. There's some things that should not be viewed through a partisan scope. And so when I grew up, we saw people die. And today, we see people die. When I grew up, we saw people at a very young age having strokes, heart attacks, diabetes. And today, we see people having heart attacks, strokes, diabetes. We can and we must do better. I'm so honored, as my colleague, Representative Costa, mentioned. I'm just about almost 10 months into my current role as a member of Congress, but I've served a lifetime in public life, serving on the City Council in New Orleans, serving in the House of Representatives in Louisiana, serving on the Senate in Louisiana, and now a member of Congress. And I'm honored to serve with these individuals who have been in the battle in Congress, fighting for, whether it's BBB or healthy outcomes or momnibus or so many other things. Honored to serve with you guys and happy to be here today.
All right. Well, thank you for your service. And one thing I want to note about these three members is that they're lifelong servants and public leaders in public policy. I know that you all served in the State House or in local city governments. We appreciate all that work as well. One thing I want to piggyback off of earlier that Representative Costa talked about is the healthcare workforce shortage. And I just wanted to know, like, what are some things that you think need to be done to sort of address that? And what are any ideas that you have to get more doctors in your community?
Well, thank you. We've learned in my area that partnerships make a big difference. And we've had a partnership with the University of California, San Francisco, UCSF, for 45 years that has allowed us to work to provide resident training for physicians. And there are a combination of factors why you have physician shortages in certain regions and nurses as well, and other techs. And we think that we really haven't properly addressed that. So the legislation that I spoke of earlier would provide $1 billion in grants for medical school construction, expansion, and training in underserved communities. It would focus on recruitment, enrollment, and retain students of disadvantaged backgrounds. We think oftentimes that if you get students from a region to go to the medical school, they're more likely to practice there than to go elsewhere. And in this resident program that we've had with UCSF, half the physicians that have completed the program have stayed to practice in the region. That's a big thing, and I think that we've seen examples of that elsewhere. Also to expand curriculum to emphasize care for rural areas and underserved areas, hire faculty from racial and ethnic groups that are underrepresented in the healthcare workforce, and supporting education programs, and then of course modernizing the infrastructure for medical schools. And there's a lot of different ways you can do this. For example, this effort that I'm working in my region, and it applies to other regions, if you go to medical school at UCLA, some of you know UCLA, or UC Davis, they've got freestanding hospitals that are on the campus. And that's kind of the traditional model, but that's expensive. It's very expensive to build a new freestanding hospital. So what we've taken, and we've developed one down in Riverside area in Southern California, and that's what we're trying to do in our area, what we call a distributive model. And by a distributive model, we have a new University of California in Merced, and we're working to develop we've already gotten $200 million from the state, a partnership to build a medical science school there on that campus for the undergraduate work. And then in Fresno, the area that I live in, which is 50 miles south of this new university, to combine a partnership with the University of California, San Francisco, this existing residence program, and use the existing hospital system that's there. Probably some of you never heard of Fresno, but it's the 5th largest city in California. And it has the 2nd largest hospital in California, 1,200 beds. And it's got the highest ER utilization in Fresno. You talk about waiting lines and gurneys and ER, people trying to get, and so the disparities are there, but it's one of only 5 trauma and burn center units. We have a Catholic hospital, we have a veterans hospital, we have a children's hospital. So why reinvent the wheel? So they do their undergraduate work, and then they come and do their graduate work there in the existing infrastructure. So we're saving money. And we think that distributed model can apply elsewhere. But I want to let other people talk. But there's there's just a lot of social, I'm going to say something that, I think is true for all of us. My mom told me as a young kid, Jim, you don't have health, you don't have anything, right? And that's what's the importance of this conference that you put together, because it's dealing with trying to make sure how, I have a majority district, I suspect, like my colleagues here, and it's different in every region of our country, but you've got all sorts of challenges that we have that include language barriers. You've got challenges of transportation. We were talking about the distances in our district. I mean, from the northern portion of my district to the southern portion of my district is almost 2 hours drive. And then you've got mental health and substance abuse issues. And that was even before the COVID thing. So these are all challenges to deal with the inequities and the access. And that's why I think plussing up our support, and it's become really perverse with our nurses. What heroes and heroines, I'll say that again, but they're burned out, like a lot of our physicians burn out. And we have shortages now, and they're getting paid so much to be rotating and to leave their permanent hospital, that the hospitals are now experiencing shortages, and they're having to spend 3 or 4 times as much for a rotating nurse, which is crazy. So these are things we got to deal with.
Thanks for those points. I want to follow up again. Congressman Carter mentioned a lot of the issues in maternal health, maternal mortality. I know that Congresswoman Kelly has been a leader on that in the Mamas Act that I think you introduced in 2017 initially? 2018. So I just wanted could you tell us a little bit about that and what's sort of in that legislation that helps deal with the problem that he mentioned?
Well, first of all, until about 6 years ago, I didn't even realize maternal mortality and morbidity was even an issue in the United States. And I was contacted by Judge Hatchett, who you might see on TV, and learned about what happened to her daughter-in-law, who was healthy, intelligent, had money, married to her son Charles, was in a good hospital in Los Angeles, and how she lost her life. So we had a forum in Washington, D.C., and so many people came. And, you know, I just started hearing story after story. So we worked with the stakeholders, the professionals, and we came up with what we called the Mamas Act. And it dealt with a few things. One was extending the postpartum period from 60 days to a year with Medicaid coverage, because it doesn't just happen that day. It can happen, you know, 30 days after 60 up to a year. And we heard many stories that, you know, everybody didn't die, but we heard different stories of what happened to women. So we put that in there. And actually that made it into the American Rescue Plan, but it's not permanent. And Build Back Better, it would have been permanent. I'm proud to say that my state of Illinois actually was the first state to extend to 1 year. So that's a great thing, because Black women in Illinois die 6 times the rate of white women in Illinois. But the other thing is we had, in the other part of it, a review committee, because we learned that Philadelphia started a review committee and their incidences went down 75%. We wanted to know, why did things happen in some hospitals and not other hospitals? So we wanted to know what what did that hospital do that maybe this hospital didn't do? What were the best practices? And the other thing is, and I know you guys talked about it earlier, but the term cultural competency, I don't exactly like that term, but we wanted to make sure that healthcare professionals, even if they didn't look like the person they were serving, they had an appreciation or understanding of where that person was coming from, and they valued their patient no matter who it was. So like I said, we got the first part. It was separated, not by me, the bill, but it was separated. And so the Medicaid part, as I just explained, got into the American Rescue Plan. The other part, we're still trying to push through, and it is bipartisan, what we're trying to push through, but it was very frustrating, because when it was the whole thing together, the Mamas Act, I couldn't get one Republican on the bill. And the interesting part was, it was a lot of the so-called red states that had the worst incidences of maternal mortality and morbidity. And when I got people on, because we kind of, you know, took some of the juice out of the bill, I'll put it like that, you know, and so then people signed on to the bill. So it is, that other part of the bill is bipartisan now, and we're hoping it pass out of committee, and we're hoping that it gets brought up, because it's frustrating, because people are dying, you know, every day. And as was said, you know, Beyonce went through this. We had Allison Felix, the Olympian. I testified with her, and next week I'm actually doing a podcast with Tatiana Ali, if you remember her from Fresh Prince, yeah, and Grown Up Now. But we're doing a podcast together, and she actually testified at a hearing I ran in oversight. So again, we're one of the worst in the world, you know, and that there's just no excuse for that.
I appreciate that. I think one thing that we're learning or we're hearing is that it takes a lot for a bill to become a law, whether you have challenges within Congress itself, or you have challenges with a variety of things. And I noticed with this legislation that was being proposed, you work a lot with nonprofits. The Tri-Caucus came together to put it together. You're going to be working with the administration. And then we have a lot of folks in here between academia and industry. And so how do you guys see you maybe partnering with academia and industry to push HEAA along?
Well, we do it all the time, and I know Anita and her team, I mean, they've been here, you know, for a long time, or it must feel like a long time, but we in all of our bills, though, we make sure that we go to all the stakeholders and get their input. Sometimes, they may say, you need to change that or whatever, but we try to go to the people that it's going to affect the most, and see what they think. Like with the Mamas Act, we work with ACOG a tremendous amount, and some of the African-American women's groups also to put the bill together. But no, everybody's important. Everybody that's at this conference, everyone, whether you're corporate or academic or a victim of what's been happening, we need to hear from everybody.
Yeah, but let me just follow up on that, because we're talking about critical legislative efforts that all three of us share in. But getting comprehensive legislation passed, especially in this environment that we are in, is hard. It's really hard. I've been there 18 years. I've been in the minority, I've been in the majority, I've been in the minority, and I'm back in the majority.
Yeah.
And I can tell you, there's a lot of difference. A lot of difference. And God bless our activists and folks who, are passionate. We're all passionate, right? But we got the smallest of margins. It's 50-50 tie in the Senate. And if we get all of our 50 Democratic senators, then the vice president breaks the tie. And we've got about a 4-vote margin now that our good friend has come and joined us in the House. And that we're all and so to Congresswoman Kelly's comment, I mean, if you get bipartisan support, that makes a big difference. That makes a big difference. And if it's just, the American Rescue Plan passed only with Democratic votes. So think about that. I mean, we've done a lot in 12 months with the bipartisan infrastructure bill was good, and we're going back at it. I never liked Build Back Better slogan. I thought people didn't know what the hell we were building. and better, I don't know. I like better, but people maybe thought it was butter. I don't know. So it's hard, and so we're looking at Jim Clyburn's, our good friend, is working with Joe Manchin to figure out where we can piece together a fallback on some of this good stuff that we're talking about here. And of course, we're in an election year. And so we got to get done what we got to get done here sooner than later. I can just tell you that.
And if I could just add a little piece to that. The reality is we don't have a patent on getting things right. We don't get elected to Congress and become all-knowing. We don't get a box of wisdom and a magic wand. So to attempt to govern in a vacuum is a mistake. And so we try to engage with stakeholders, with academia, with social leaders and civic leaders and business community, because it's through this process that we come up with a better product. And sometimes we get it wrong. And sometimes through that kind of collaboration, we end up with a better product. And it's also better to govern while listening to the people that you're attempting to govern for. In an attempt to do things in a vacuum, oftentimes get you missing very important parts of the process, as well as unintended consequences. While you're attempting to fix X, you break Z, Y, and others.
And the law of unintended consequences is always there.
Ever present.
That law is always present.
Yes.
I'm just gonna, two things you mentioned, but I'm gonna welcome folks to start lining up if you have a question, because this is maybe one of the last questions that I ask. And Congressman Carter just said, listen to the people that you govern for better information. So I'm gonna let the folks in the audience go ahead and ask questions. Another thing he mentioned is that we don't get a magic wand. And actually right here in one of my questions, it says, well, if you do have a magic wand, and if you did have a magic wand, what's one or two items, healthcare related or an HEAA, that you would love to see passed? Because remember, you have the magic wand. So what is your magic wand passing?
Well, for me, I mean, I ran on the issue, we have got to do something about gun violence in America. I mean, it is truly a public health crisis. I'm not against guns, but I'm against all of this when, I mean, where I live, you can't drive down. I met with the state police and over 200 people were shot on the expressway. I mean, you can't even get home. When I have to go to something at night in Chicago, usually I get a hotel room and my husband and I stay over and drive back in the morning. That should not be, you know, the road rage, the people getting hurt from carjackings. I mean, that, you know, that's my, because too many people have died. Too many people have died. Last year in Chicago, I think there was 800 and something that died. I'm not talking about who was shot and maimed and had to live with their injuries, you know. And I know people like to say it's just gangs, but it may be some gang shooting, but it's innocent people, you know, taking the shot. So definitely gun violence prevention. And I know we're talking about healthcare, and I just said maternal mortality means the world to me, but it's something about if I had the magic wand to give people hope and opportunity, because I always said nothing stops a bullet-like opportunity. And I think that, you know, when we all do better, when we have jobs and feel good about what we're doing, then we all do better. So I don't know what that wish is, but you know, whatever that wand is.
I think that's, earlier would say that's dealing with the social determinants of health.
Yeah, I guess
And
so.
having an opportunity for all.
Yeah.
Magic wand.
You're talking about, I mean, it was a massive build that we started off with in the Build Back Whatever. I will tell my colleagues, I think will agree with me, if you don't have a sense of humor in Washington, you could very quickly be committed. It's because some of the stuff you can't make up. There were critical priorities in all of those areas, but as it relates to the issue that I'm trying to focus on here with the healthcare inequities, I think it was so important to complete the work that we started in 2010 with the Affordable Health Care Act, as my colleague said, the Obamacare. And let me tell you why. As I told you, I come from a district that has significant poverty. Almost 25% of my constituents are on food stamps. Think about that, a quarter of your constituency. That gives you an indication, a descriptive, I'm drawing you a picture. There's significant wealth as well. But when we voted on that in 2010, and I can just tell you that we had to use the reconciliation process, and it was just so painful. In a district that had, in mine, that had 24% of the constituents with no health care insurance whatsoever, and 17% underinsured. We polled just before the November election in September. And you'd think people would be excited about this, right? A minority majority district, you know, 24% no insurance, 17% underinsured. 54% of my constituents hated Obamacare. 36% supported it, and the rest weren't sure what it was. Now let me give you the success story. Last year, we looked in the area, and of course now it's overwhelmingly popular. But now that's uninsured's gone from 24% of my district to 10%. That's a big success in 11 years. And the underinsured has diminished as well. And what never gets talked about, but in a rural area like I represent, the $8 billion that we provided for federally qualified healthcare clinics in America. Man, all of my clinics have expanded, and they're providing healthcare from young to old and anyone in between, and dental care, and in rural areas with transportation. And one of the neat things that these clinics have done, they're putting clinics in schools. You know, I mean, you got, you know, clinics in middle schools and high schools in the neighborhood. So when the kids go, you know, the parents go, And that's made up a big difference. So my priority in the Build Back Better was to complete the effort of the Affordable Health Care Act. To, these Republicans, and Robin shared a part of this, for the 8 years they were in the majority, I voted not once, not 22 times, not 53 times, not 64 times, but over 70 times to oppose repealing the Affordable Health Care Act. This was mindless, with nothing to replace it with. I mean, what were they thinking? My gosh. Repeal it for 8 years. It was the big deal. I mean, they'd run it up the flagpole, almost every week, and we would vote it down. So I want to complete that job as we talk about then expanding, if I had a magic wand, the other efforts that are necessary to deal with the inequities and the disparities and the access to what my mom said, Jim, if you don't have health care, you don't have it. Every American ought to have access to good, equitable health care regardless of where you live.
Yeah, I just wanted I was around for most of those votes also.
We voted a lot of those together.
And when I wasn't there when the ACA passed, but no one said that it was a perfect bill.
Yeah.
We said, let it get rolling and then let's make the corrections on the way, but they never let us. We never could do it because we just didn't have enough members that would help to make the improvements that it still needs,
Right.
But we just never had the opportunity to do it.
And we're trying to do that in the Build Back Better.
Congressman?
And very few bills are perfect.
Never seen one that I've.
I mean, they all require, that's a part of that. We don't have a patent on getting it right. You tweak it as you go. If I had a magic wand, I guess the first thing I'd do is I'd make a few more magic wands.
Smart guy.
But then second, I would, because I think this particular issue has a ripple effect on so many others, I'd eradicate racism from its very core. Because when you eradicate racism, those healthcare disparities, many of which go away. Educational opportunities increase, and the challenges for equitable education goes away. Business opportunities for African American and minority-owned businesses and women-owned businesses go away because they have access to capital, they have access to banking relationships, by and large, that are thwarted because of racial underpinnings. Housing opportunities, hunger and poverty goes away. Healthcare disparities go away. Crime in our communities at the hands of police officers who are sworn to protect goes away. The George Floyds of the world doesn't happen because you don't have rogue racist cops who see nothing but the color of one's skin, and instead of providing justice, provides injustice. Racism would cure those things. Unemployment, underemployment goes away when fairness in the workplace is allowed to be recognized. Intolerance because of who you choose to love or how you choose to love or where you choose to live or how you choose to worship or if you choose to worship at all goes away when racism and intolerance goes away. So if I had a magic wand, our lives would be a lot easier because many of the things that we fight for every day are rooted in racism, rooted in inequities, rooted in sexism and biases that have damaged our communities and damaged America more than we can ever speak of.
Yeah, thank you for that. And it's interesting, I know that the other Brandon is here, and we worked last year on our summit, and his brother did as I think a law professor and a med school professor, and he did a whole paper study called Racism Makes Me Sick, and it talked about all the ways that racism does indeed make us sick. With that, I'm going to turn it over for our first question from the audience.
Hi there, thanks so much. I really wanted to thank Representative Troy Carter for talking a little bit more about racism, and while we don't share common ancestry, we do share common history. And for those of you who don't know, Louisiana has a long history of Asian Americans and Black Americans working together and cooperating to make sure that we help each other. And for Troy Carter, the seat was Cedric Richmond's. Before Cedric Richmond's, the seat was Joseph Cao, the first Vietnamese American member of Congress. And what else our communities have in common is poverty, language access issues, but also the need for culturally competent care. And we need more people of color to be in medicine, to be in research, but we also need doctors of color, pharmacists of color, neurologists of color, and industry is poised to help. So my company, Biogen, has made a commitment. We have a community lab with MIT where we work with over 57,000 students in 10 years to make sure kids of color get a chance at STEM. We work with the Harvard Chan School to make sure that we have Black and Latin fellows in neurology, and the Morehouse Medical School. We do summer internships and would love to partner with Xavier. So my question for the members of Congress is, how can industry partner? How can we help you to achieve the goals so that we all benefit?
I'll start. You mentioned some of them. We've got some of these incredibly bright young people. Provide internships, as I'm sure you do. Enhance it. And as at least one of the physicians spoke of, don't wait for them to come to you. Go out and ask. Go to the high schools, go to the communities, provide resources, provide paid internships. Because oftentimes internships that are available and they require you to travel and have housing, that's prohibitive in most cases. So create those kinds of opportunities that make it easier for our best and brightest to access the resources that you have. Talk about the opportunities within your organization for meaningful employment. Provide scholarships so people will be interested in coming into a specific field for minorities and people of different origin and backgrounds who historically may not have had those opportunities. And lastly, provide the kind of community involvement to, even if it's not in your specific area of expertise. We've got hungry people. We've got communities that need playground equipment. These things are barriers and these things that make a difference in people's lives. If their quality of life is improved, the chances of them seeking higher education and having an academically successful venture also increases. So there are a plethora of ways, but that's a handful.
I also think it would be helpful if companies, I agree, go into the schools early, but if you want to get into healthcare, you don't have to be a doctor or you don't have to be a nurse. There's so many other aspects of healthcare, but people or young people don't know what they are, so they might just say, I don't want to be a doctor or a nurse. And I think that we need to help expose them, spread their horizons, bring them in, give them a tour, let them speak to different people, then stay connected, to that young person or to that school. And then the other thing is, once the person is a professional, I'm jumping ahead, a big thing is those student loans. Good God. I mean, I met a dentist that told me she owed $400,000. She'll never move out of her mommy's house, so having some kind of program like we actually do in the federal government where we help people that work for us pay back their student loans, I think that would help also, because some people don't even want to deal with it.
I concur with all of the above, and I'm a big believer in public-private partnerships. And I think we see a number of the folks here that are participating from the private sector that add value and in so many different ways. And I would just indicate that we are looking at trying to provide relief for those physicians and nurses that agree to practice in underserved areas in minority communities to help with paying off their medical school. So I think there's a number of tools that we have to put together, working together with this partnership, not just at the state, at the federal and local level, but I think at the state level as well. To the degree that we can leverage resources. But I think, really, it's one of the reasons I like these clinics in the schools, a lot of them in minority communities that never had access, and you talked about preventive care earlier, these are all opportunities, but I guess as we struggle to do better, how we have a strategy of both short-term and long-term goals that we can agree upon is not fleshed out as well as I think it should be on how you get there from here.
Well, thank you. And before you exit, I just want to make sure I get 2 hands raised. VP Bell and VP Adams. I heard her say, as a trustee for the university, I heard her say Biogen wants to work with Xavier, so just making sure you all met.
And did I hear somebody say endowed chair?
Yeah. I heard $5 million, but I'll let the next question come out.
Let me take my seat. Hello, and thank you again for being here. My name is Erica McConduit, and I lead Diversity, Equity, and Inclusion for Centene Corporation, one of the sponsors of this event. Troy, we go way back.
Yes.
I was an advocate. I previously served as president and CEO of the Urban League of Louisiana. So I come at this work from many different angles. I guess my question to you, because right now I am on the private side, and we're partnering with Xavier. I'm already at the table, no worries.
I was going to ask.
Yes, we are.
You're doing your work.
We came with our checkbook, no worries. But beyond that, I also serve on Louisiana's state board for our community colleges. And I'm asking because how, from the congressional side, do you guys assist in making sure that you level the playing field? Yes, for debt relief and student loan forgiveness and things like that, but it's very hard. I'm a graduate of Howard University. I believe in HBCUs, but it's very hard for community colleges and HBCUs to compete, right? I'm right now bringing Centene to look at Howard's dental school, the facilities, right, the infrastructure. Literally, I was on a conference call with them and the lab ceiling fell in. It makes it very hard for HBCUs to compete. Same for community colleges, right? When we're trying to attract the same level of quality talent, right? When we know that those kinds of institutions focus more on going back, sending their graduates back into communities to provide that culturally competent care that we all know is sorely needed and missing from the pipeline, from the workforce, from all of the established healthcare providers. So I'm just wondering, what are you guys planning to take on to really assist those critical universities in building up more attractive and resilient infrastructure so that they can attract the student body and compete?
Let me just comment from a California perspective. We have a master plan that was initiated in the 1950s. We now have 116 community colleges in California, educating almost 3 million students. We have 23 state universities, educating almost 500,000 students. And the University of California, with 10 campuses now, has an enrollment of almost 300. So you add that community college, state university, but we have some terrific, in my area, nursing programs at 2 of my community colleges, at Merced and at Fresno City College. And we also have a nursing program at the Fresno State University. And we're looking at bridging, again, trying to leverage resources, the community college at Fresno City with the Fresno State nursing program, because believe it or not, it's a 2-year wait to get in to the nursing program at Fresno State. And this is an area that has an acute shortage of nurses. It's crazy. And so there's legislation that complements the medical schools that for nursing schools that I think we're all supportive the Tri-Caucus is, and it would provide the same amount of funding if we could get it passed to build on those community colleges that have nursing programs and other colleges that have nursing programs as well.
That's a really good question because I'm in Illinois. We have no HBCUs, but we have community colleges. But the other thing we have are minority serving institutions, which, and that's a whole different ball game. And I might be wrong, Troy can correct me, but I think this year HBCUs got more than we've ever given them. But the problem is, because Alma Adams is the godmother, that, like you said, buildings are falling apart. And, even though they receive more money than they ever received because they're not in great shape, they need more money. But then the minority serving institutions are saying, what about us? Because they don't get, as much money. And then there's the community colleges. And one thing when different people running for president talked about the first 2 years, like community college, that should be free. And that's what I know a lot of CBC members were concerned about, that would kill HBCUs, which we have to preserve just because of their place in history, the legacy and all of that. We cannot, let those doors close. But I can't even tell you that I have the answer, but I know Bobby Scott, the head of Ed and Labor, works really, really hard on trying to get the resources to, whether it's 2-year or minority serving or HBCUs. And as I said, this year, we did the most we've ever done, but more is needed because of what hasn't been done, in the past. But I don't know if you know.
And Congressman Kelly is absolutely correct. We've allocated more money to HBCUs this year than ever before, under the leadership of Chairman Bobby Scott, Ed and Labor, who has done an incredible job of weaning through the numbers, of finding creative ways to make sure that those inequities of the past have been addressed, are being addressed, I should say. Elma Adams, who's everything HBCU, who's our colleague who has made it her cause célèbre to fight for and to advocate and to be there to talk about those things that are important, not just for the classroom experience, but the overall experience. And the experience that you talk about, the brick and mortar, through infrastructure and Build Back Better, these are areas where we've attempted to provide those resources. But as was mentioned, we ask corporate America to invest in the classroom experience, but also in the physical place. Because there has to be a lab, there has to be a library, there has to be exercise space. Qatar, for example, the pharmacy building right here at Xavier University is the product of a huge investment from Qatar. So we have people recognizing, countries recognizing the value of HBCUs and what they do for the world. Not just the academic experience, but the brick and mortar that allows for the academic experience. So we talk about that public-private partnership. We talk about how we work together from a policy standpoint and how we listen to corporate and academia and social and community. This is another example of how we do that. Thank you for a very insightful question.
Thank you. And thanks for your work with everyone, especially the folks at.
And thanks for bringing your checkbook too.
Yes, ma'am.
Hi, and I want to first thank all of you for your service and for your work that you do.
Thank you.
It is very much appreciated. And thank you so much for your work on maternal mortality and maternal morbidity. I am Deborah Frazier, the CEO of National Health Restart Association, and that work speaks very much to the work that we do to decrease the disparity in infant and maternal mortality. And you spoke about that being near and dear to your heart as it is to mine. And as tragic as infant mortality and maternal mortality is, and I want to reiterate that for every death of a woman, there are another 100 women who suffer a severe morbidity. And that is where I think we all have a wonderful opportunity to improve women's health. And in the bill that you put forth, that I think we should all get behind. And because that, I think, is a salvation for improving the morbidity and mortality for women around the country. And it's sad that this country lags so far behind other countries. So thank you for that. And anything that I think all of us in this room can do to help with that, I think we are willing to do. Because for us, we're a national organization. So we get tips from Lauren Underwood's office, sometimes social media. So anything that we can do to support the work that you do, when you guys can pass bills that help this country, and we can get information back from you, then that helps the entire country. So let us know what we can do to support you in the work that you do. We have pilot projects now in Fresno and in New Orleans on reducing maternal mortality and morbidity.
Wonderful.
So what we can do, we can help you.
Thank you.
Maternal morbidity and mortality is increasing as a result of COVID. And not necessarily because of COVID exposure. It's because COVID has reallocated public health resources. Just as perinatal syphilis has increased because of COVID resources being allocated. So thank you again for your work, and let us know what we can do to support you and help you.
I will take you up on that. Thank you.
Thank you very much.
Thank you.
And this gentleman, we say his name is Mr. Clyburn there, but here in New Orleans it's Claiborne. So Mr. Claiborne, go ahead and.
Claiborne, Clipsburg, Clydesdale, I get it all. So I wasn't so sure as why I was coming down to New Orleans after Mardi Gras, but I'm so glad that I did make the trip because on this trip, for the first time, I got a chance to meet this Biogen executive who's actually here taking notes and saying, sign me up, let me get involved. That's pretty incredible. And Ms. Frazier, first time meeting her in person, when you're talking about infant mortality and infant morbidity, maternal mortality, maternal morbidity, I mean, those are some serious issues. And it's just stuck in my mind, Congressman Carter, I tell you, you got the hometown advantage. The story you were telling, I can't get it out of my head about dragging half of their bodies. What is he talking about? And I can't get it out of my head because, not because it's so graphic, but because I see it so often. It's so present. And how do we get around that? And so one of the things I've heard consistently throughout the whole day, even on the panel, about systemic issues, it was about something that isn't so exciting, something that's very boring and mundane and very nuanced. It's about the guidelines or what are the regulations that are coming out of the federal government that these discrepancies are baked in. And so how do you unravel that to talk to HHS and HEAA and CMS and FDA so that they see what we see and address some of these very consistent issues? And so how do we work with you and your staff so that we can get to those regs so that it can come down and actually make a big difference in these discrepancies and disparities that we're dealing with?
You know, one thing that I feel good about, like, because President Biden and some of the people that he picked to run, you know, his cabinet, we know them up close and personal, you know, like Marsha Fudge from HUD, like Becerra, you know, HHS, Mayor Pete for transportation. So I feel it's easier than it has been, you know, the last 4 years to contact our liaisons, contact them directly and say, are you aware of XYZ? I mean, some of them and the others have been in my community. Marsha was there to fix some things that went haywire in Chicago with some of the places, and Mayor Pete has been around, and Becerra, I've been on, you know, Zooms with him, and you know, it's easier when you have a relationship with people and you know people. So if there are things that, like someone just told me about something that was in Build Back Better that probably people didn't realize, that should not be in there, but if you tell us, we contact our liaison or contact them directly and say, hey, were you aware of this, or what do you think about that? And that comes in handy when, you've built relations with people. And it seems like, in my experience, since he's been the president, that his folks are present and want to, do things better. They want to build back better.
Well, I agree. I mean, we have all different relationships with the team that President Biden has assembled, but it's a good team. People that come from various backgrounds that, we work with, whether it's our Secretary of Housing or Transportation. I mean, I have a little bit of advantage with Secretary Becerra. Javier and I served together in the state legislature, so we go way back. And his wife's from Fresno. She's a physician. So she knows about the inequities of healthcare in the San Joaquin Valley, and I remind him of it all the time. He has family in my district. But one other thing that we talked about here in different ways that has not been mentioned, and I'm, again, going back to my upbringing, is healthcare prevention. I mean, so many of the issues, and we're trying to change that with my friend Tom Vilsack at USDA in terms of the school lunch program, in terms of getting good, healthy habits. I mean, that cheeseburger you were talking about versus the salad. I mean, it's one reason we have such severe issues of obesity in our communities, especially among minority folks, and diabetes in the Hispanic communities is really a challenge. And it really comes from just not as a young kid, and we're working on trying with Secretary Vilsack to change the requirements on the school lunch and breakfast program so that we can get more, that's the old notion, an ounce of prevention's worth a pound of cure. I think we got to, in all of this, getting back to that strategy and how we get there, I think we got to focus on some of the preventive healthcare maintenance issues. I mean, I just think that's a wise investment.
And Will, you already do a lot of this already. It's communication, bringing your corporate clients, bringing them to us and engaging us and having the opportunity to talk back and forth. And if I were to look in the face of corporations, I'd ask them, when we try to simplify those regulations, don't fight us. When we look at ways to make them fairer and more inclusive, don't fight us. When we attempt to change the paradigm of how things have, quote unquote, always worked, well, often things that's always worked hadn't worked. So listen to us, and we'll listen to you, and we stay at the table together and figure out how we can have meaningful exchanges on how to make best practices better. When you listen to the communities that have historically been kind of left out of that process, and gives us an opportunity to do that. And we talk about those relationships with cabinet members. Louisiana's been very fortunate. We have my dear friend, your dear friend, Cedric Richmond, who serves as senior advisor to the President of the United States, who's the former congressman for this very district, a product of this very community, a great friend of ours and a great ally for everything good for America and the American people.
And a great baseball player.
And a great baseball player. Shoes that I couldn't fill. We have the director of the White House Budget Office, a Louisiana lady. We have the ambassador, a Louisiana lady. We have our infrastructure czar, Mitch Landrieu, the former mayor of New Orleans. And we can go on. We've got the kind of presence that the Biden administration has brought to all of our districts is people you know, people that know you, people that are close to the ground, not people that are plucked from nowhere to come and serve, that don't have the kind of hands-on approach of understanding the pain the hunger, the suffering, the inequities that our communities have faced, because they have been in the battle fighting. Every one of these people that I mentioned, all the ones that have been mentioned by my colleagues, these are people that have been in the trenches fighting for the people, hearing the pain and hearing the suffering. And that's what I love so much about this administration. It's an administration that really cares about people.
Thank you.
I was gonna let you be the last, but with 795 tackles and a few touchdowns and a gold jacket and growing up in Holly Grove and going to Southern, I'll go ahead and let you go.
You've earned your place.
Exactly. No, appreciate it. Thank each of you all for your public service. I am so honored to be here. Pro Football Hall of Fame. I grew up right down the street from here, attended Upward Bound on this campus. I probably learned more in 20 minutes talking to President Dr. Garrett about New Orleans than I knew Troy for quite some time, the history of it. My wife and I pastor a church in St. Louis, so we're right across the border from you in your area of oversight. I really have a question as to, and I also serve on the committee with the National Football League, the Inspire Change Initiative, where $250 million are earmarked over, it'll be 8 more years, disparities in putting income and financial resources in some of our communities. But the reason I'm here, I got invited by Centene and their partnership with the Pro Football Hall of Fame. And on an earlier panel, I was listening to Dr. Gary. And Dr. Gary mentioned that decisions are made for the majority of our people of color by people who make policies, but yet all the communities impacted. So here's the question. One, the arduous task of having a responsibility to be at the table on behalf of others. What is that challenge? And the second thing, how do you get things done? And this is particularly for the younger generation that may see sometimes the politics, and it looks like it's hard to get anything done. What's the process of working with people who have their own ideas? How have you guys been able to get things done?
When I came to Congress, I was in the minority, I think my first 5 or 6 years, but I've always worked in a bipartisan way. And my first bill I passed had to do with dental coverage for low-income communities, and I worked with 4 Republican dentists and myself, and we got the bill passed. But I will admit, after January 6th, it's been harder for me. I was one of the last people out on my hands and knees with 15 other colleagues in the gallery hiding. And
We were both there together.
And so that's made it a little tougher, especially when they say it was just public discourse, no big deal. And we heard the woman get shot and killed, and actually that, made them pause so they could get us out. And we ran downstairs and through hallways to get to an undisclosed location. But despite all that, we still get things done. And to be honest, I don't know how they feel, but we all get along better than people think. I mean, the media, gets a lot of hype and talks about a lot of things. And it is frustrating sometimes, I'm not gonna lie, and I think the people are a little bit, I'll just say, Taylor Greene and Bobart, they're a little bit different than people that we've dealt with, in the past. But you were sent there to get something done, and I just keep trying. My staff keeps trying. When we have legislation, we call Republicans, not all of them, but call Republicans and to see, if they're willing to work with us on staff. I know Anita has been, calling all over for a bill that we want to introduce. So we do get things done, like the American Rescue Plan, like, even though no Republican was on it, and the infrastructure bill that was bipartisan, we got that done. But it is more difficult now. I will admit to that, but it's not that we're, tearing each other's eyeballs out. And there's a no labels group and a problem solvers group. You know, those are Democrats and Republicans. You just don't hear about it.
Right.
You know, like something happened the other day where a reporter said to Val Demings, ex-police chief, well, you guys want to defund the police. She's an ex-police chief. Why would she want to defund the police? And so I got up and I said, you know, there's a few people that feel like that, but the majority of us do not feel like that. We may feel like there needs to be reallocation, and we do believe police need to be held accountable, but you don't hear us running around saying that. It's you running around saying it and making a bigger, you know, issue of it than it, you know, really is. So I'm saying all that to say, we do work together more than people think. I think you're just seeing a little bit more how the sausage gets made, and it could be ugly, but it is a little more difficult now because of who's at the table, but I still think we get things done.
No, I
in my
agree.
opinion.
No, we've really got more done in the last 12 months or so, 13 months than comparatively in the previous 4 years. And the president said it, and you may have heard on the State of the Union, he signed, I think, what did he say, 84 or 82 bipartisan pieces of legislation? That gets overlooked. I mean, you know, lawmaking, as my friend said, is akin to sausage making. It's not pretty. What's that old line? If you have a respect for the law and you like to eat sausage, you'll see either one of them being made. But the fact is we're all focused, as you point out, on getting things done. We go there with passion and a desire to represent our constituency, and we have priorities, but we want to get things done. And it's hard. But that notwithstanding, we've gotten a great deal done in the last 13 months with President Biden, and a lot of it's under the radar screen, but bipartisan. I mean, the Build Back, the bipartisan infrastructure package is the largest investment in infrastructure in 40 years. And
since the very interstate was built.
Right, you know, and but the press likes to focus clearly on division, and I get that. That's, but all the different things that we try to figure out ways to get things done. That's why we're there.
Let me give you one more crack at that before you leave, Aeneas, because I want to thank you before you leave the stage. Thank you for being such an incredible role model, somebody that came right out of this community. And you and I had a little bit of a sidebar earlier, and we talked about something that we can all do a better job at, and that is not only letting our young people see the finished product, the success story, but to share with them that, you know, you grew up in Holly Grove, I grew up in Algiers, we grew up in areas in challenged communities that could have been different, and many of us did. And we had our own obstacles and our own challenges to overcome. And it's important to be able to hold people like you up, to talk about, yes, your academic prowess, but also your professional and business and clergy prowess, that your success is not limited to how fast you can run, how hard you can hit, but also the ability to think and process and be a successful person. So kudos to you, and more people should have that opportunity, and we should let our young people see that there is a totality of what makes us successful. And a part of that success is sometimes failing, sometimes not getting it right. So to go real quickly into your question, what's it like to be at the table? It's a blessing. It's a blessing to serve. It's a blessing to be at the table, even when you don't always get your way. Just being at the table, you get an opportunity to inject those issues, those questions, those solutions that otherwise wouldn't even be discussed.
All right, I'm going to make this our last question, and following the question and final remarks, we're also going to have remarks on the screen from the Asian Pacific Islander leads from next Congress. So, Aquarius.
Thank you, Brandon. My name is Aquarius Gilmer. I'm here from Gilead Sciences, one of the sponsors of this wonderful conference. Thanks for the hybrid opportunity. And also, thank you for your work. I really enjoy listening to all that you had to say this afternoon, especially around being thought partners with industry. Oftentimes, it's not always understood that sometimes we do see unintended consequences. And we do, in my work, a lot of work around HIV and triple-negative breast cancer, two of which disparities, thank you for taking the meeting, short notice this week, impacting Black women, but also Black men in various districts across the country, desperate disparities here in the South and major metropolitan areas. And so my question is, two-pronged. One, in all the work that the White House's COVID-19 Health Equity Task Force, the American Rescue Plan, and also the infrastructure bill, there are more than $52.8 billion in state coffers that are not being disseminated at the state level. What is the play, or how do we engage at the state level? We have presences in states. We're based in Foster City, California. We'd love to host you if you want to come by in California.
Take you up on that.
Absolutely. Resources are already there meant to help do much of what we talked about today, prevent gun violence through job training and job readiness, but they're being held up at the state level. If you have any insight as to how both industry and also just folks who are really interested in moving the country forward and being sort of not, unstuck and mired in this sort of stymied position that we've been in for so while, how do we address that? And my second question is around what considerations in the Build Back Better Act, or BBBA, are you reconsidering or reimagining? If you're willing to say that publicly, or should that be some of the conversation on the side that we could talk about in terms of unintended consequences as it relates to what would happen to the access of innovative medicines that impact Black and brown people the most in terms of disparities and the care that they need, being either highly treatment experienced, vis-a-vis that they're comorbidity, so it's not just one thing that they're dealing with. What are those considerations that you're thinking through? And I'd love to hear your thoughts on either or both of those questions.
I was so concentrated on the second one.
Okay.
Remind me of the first.
The first one was
how
about
to get the states.
monies, yes.
I remember when we first started getting money together to give to the states, there were a lot of different complaints, like the people that came from red states, they were saying that their governor was holding up money because maybe they were Democratic cities in those red states. But then also there were blue states that the governor was taking his time disseminating the money. And I know we changed, at first it was if you were 500,000 or more, you would get the money directly. Then we changed it to 50,000 or more, but no place in my district even has 50,000 people, because I'm suburban and rural mostly, and then a piece of Chicago. But I haven't really heard that much about. I know some places said that they don't have everything, like all the rules and regs, aren't together yet. And I don't know. I have to check into Illinois because I haven't heard any complaints. So I don't know if you have specific states in mind, not to call anybody out, but
I can definitely put you in contact, much like other advocacy groups who are working toward these goals, to really ensure that state Medicaid programs are shored up, because oftentimes they're the first programs that are cut when you have budget deficits. But now states are running surpluses and still are sort of stifling the care that could be really expanded in states.
But that's what I'm saying. I haven't heard that about Illinois, but I will check into it now that you've said it. And as far as Build Back Better, I think more what I'm thinking of now, even if we can't get the whole thing passed like it looks, like what do we need to parse out to get passed? And what I was saying about, I was just informed of an unintentional consequence when it comes to rare diseases. And that's not something I would have known on my own, that was an unintended consequence. But now that I know, I'm going to bring that up in Energy and Commerce. That's the committee I'm on, and to see what can be done about it. But I mean, it may not, Build Back Better is not going to pass like it is, so that might not even wind up being an unintended consequence, but I'm still going to make the chair aware of it.
And I'll piggyback on that. We were one of the states. Louisiana is one of those states that under our Republican Governor Bobby Jindal, who rejected the opportunity to have an expanded Medicaid. But under our Democratic governor that we now have, John Bell Edwards, one of the very first things he did when taking office was to sign for the expansion. So, those are areas where it makes a difference. And it makes a difference to be ever present. We have a Democratic governor, we have a Republican-controlled House and Senate in Louisiana. But we shouldn't let any of that be barriers to good policy, whether it's in the nation's capital or here in the legislature in Louisiana. I'm a proud Democrat and have worked very well with Republicans that are willing to come to the table, as Democrats are willing to come to the table and recognize that we should put policy above politics and talk about those things that are important for the American people. And as Congresswoman Kelly said moments ago, we get along a lot better than the national press will suggest. Now listen, there are some actors that none of us would like to be in the same room with, to be clear.
On both sides.
On both sides. on both sides. Fair, very fair. But by and large, it's driven by issue, it's driven by policy. And it's not always as dark as talking heads would like to make us believe. So we've got to continue to kind of work through that now. And on the Build Back Better piece, you're going to have a lot more time for me to answer that question the way I'd like to, because there were so many parts of Build Back Better that would systematically change the lives of American people that we're not going to give up. It may not pass under the heading of BBB. It may not pass with all of the bells and whistles that were there, but we're going to continue to fight for those components that improve the lot in the lives of the American people, whether they are Republican, Democrat, or other, because it's that important.
Thank you.
Yeah, let me just follow up on that. We're struggling right now to figure out how we put those pieces together, whether we're talking about the aspects that deal with climate change or whether it's child tax care credit are the areas that focus on a host of priorities. And I told you two of mine, the funding for medical schools and nursing schools, which was a part of the Build Back Better. How that gets piecemealed together is what we're working on right now. And I told you earlier, I hope it happens sooner than later. But I'm also very hopeful that not only with that, but I think that the president outlined 4 areas that I think there's consensus, bipartisan support. He talked about the opiate crisis. I mean, that throughout the country, right? The need to focus on veterans, right? Throughout the country and the homelessness issues that we deal with there. And then prescription drugs. I'm still hopeful that we're going to get some effort to deal with, and he talked about the cost of insulin. I mean, it's crazy. We have folks in our communities that are diabetes, and the amount that they're paying for their treatment is just, you do any kind of comparative analogy elsewhere. In terms of, how the states, it's always a challenge when you've got different states, red states, blue states. I mean, in California, we've had a very expansive, as you know, effort on our healthcare system to accept not only the Medicaid funding, but also to expand upon that, and the state making its own efforts to deal with that. But it's a different cross-cutter around the country when you look at and in some ways, sadly, it enhances the disparities that we've been talking about here this afternoon, sadly.
All right, well, thank you all so much for your insight and your work and I'm not gonna put any numbers out there, but your time in public service, and we appreciate that. I'm gonna take a bit of moderator's privilege and former chief privilege and trustee privilege and to say thanks to everyone for coming here today. Thanks to the Health Braintrust team for sort of putting on such a great show today. Thank Dr. Puckrin.
Thank you. Did someone say that Mardi Gras already passed? I thought that's why I came here.
You're just a few days short.
Yeah, because we'll keep the celebration going for you.
Very good.
And then next February. And then
We can
finally,
still whip up a little something for you.
yeah. But finally, thank President Verrett and the team at Xavier University for helping us put this together. I know without Patrice Bell and all of our questions and getting, we wouldn't been able to have this happen. So thank you so much. And with that, we're always looking towards the future. And next year, this legislation will be introduced in April at the 20th annual Summit on Health Disparities that NMQF is leading with the Spring Health Braintrust with Congresswoman Kelly, so she can't get rid of me and I can't get rid of her.
Good team.
Yeah, so that'll be in the last week in April, so we'll hopefully have all these insights taken care of and added and included to this legislation. But in looking to the future, I want to end it with our co-sponsors of the bill for next Congress, KPAC Chairwoman Chu, and the health chair there, Congresswoman Lee. So just say 5 minutes of this video and then we can all head out.
And hurricanes.
Hello, I'm Congressmember Judy Chu, and as chair of the Congressional Asian Pacific American Caucus, or KPAC, I'm so proud to be a part of the introduction of the Health Equity and Accountability Act, or what we call HEAA. For nearly 2 decades, the Congressional Tri-Caucus has worked together to introduce HEAA, which is a comprehensive set of policies to address equity, discrimination, and systemic racism in our healthcare system. This has made HEAA the shining example of how we can address health disparities in our system. And we have been able to leverage our collective efforts behind this bill to achieve real change. For example, when the Affordable Care Act was passed, many of the final provisions that made it into the bill came from HEAA. But our work wasn't done. Since then, HEAA has only grown as new members and community groups come to Congress with their ideas and ways to improve the systems that we live in. And this year is no exception. We've all seen the devastating toll that the pandemic has had on minority communities. But unfortunately, for those of us who've been working on addressing health disparities for years, it was not a surprise. We've known that critical gaps exist in our health system that leave minority communities especially vulnerable during times of crisis. For example, HEAA includes entire sections on addressing data disaggregation and language access issues and underlying health conditions for Asian American, Native Hawaiian, and Pacific Islander communities. We saw the stark need for this in the early months of the pandemic when Asian Americans were listed as other on the CDC website's COVID-19 cases count. And what's worse, because we did not have information on the impact to AAPI and Native Hawaiian communities, initial media reports suggested that COVID was not hitting these communities as hard, which we know was simply not true. As our caucuses continue to push forward with addressing these longstanding issues, continuing to update the provisions in HEAA and to reintroduce it is so critical. I would like to commend Representative Kelly and the Congressional Black Caucus for their tremendous job compiling this Congress's version. And I'm excited to work with the Tri-Caucus in pushing forward these policies this Congress. I'm happy to announce that next Congress, KPAC will be leading the introduction of HEAA. I look forward to working with KPAC's Healthcare Task Force chairs, Representative Barbara Lee and Representative Amibera, to build on that framework for the 118th Congress's version and to continue our work to enact the most crucial provisions in HEAA. Thank you all for participating in this summit. HEAA is also unique because of its collaborative nature and its emphasis on community engagement. Events like this summit are critical components of that process. So thank you again for helping us make this bill possible.
Hello, I'm Congresswoman Barbara Lee, representing the beautiful 13th Congressional District of California, which includes Oakland and Berkeley, California. As co-chair of the Health Task Force of the Congressional Asian Pacific American Caucus and a member of the Congressional Black Caucus's Health Task Force, it is a real pleasure to welcome you to the member panel. Thank you to Congressman Troy Carter for hosting the Health Equity and Accountability Act Summit at Xavier University in New Orleans. I would also like to give a special thank you to my friend and colleague, Congresswoman Robin Kelly, the CBC Health Braintrust. She has done such a phenomenal job, and also her staff for leading the reintroduction of HEAA during the 117th Congress. Also, thank you to our phenomenal CBC chair, Joyce Beatty, Congressman G.K. Butterfield, and CBC members for their continued support. In the 116th Congress, under the leadership of Congressman Chuy Garcia of the Congressional Hispanic Caucus and Congressman Joaquin Castro, the Tri-Caucus greatly advanced its health equity agenda. I would also like to thank our chair, Congresswoman Judy Chu, and my fellow CAPAC Health Task Force co-chair, Congressman Ami Bera, for their leadership. I look forward to working with them and Senator Mazie Hirono to sponsor the reintroduction of HEAA in the 118th Congress. HEAA brings together not only the Tri-Caucus, but also many stakeholders, such as the Minority Equality Forum, National Urban League, UNIDOS, Asian and Pacific Islander Health Forum, and the Association of Asian Pacific Community Health Organizations. Thank you to all of our advocates for your work to further health equity in this country. As you know, HEAA is a bold, comprehensive vision for addressing persistent ethnic and racial health disparities and improving health outcomes in communities of color. The inequities in healthcare are very well documented and they're understood, but COVID-19 exposed the gravity of the problem. This is the moment to enact HEAA to systemically improve healthcare to ensure that all Americans, no matter their race, ethnicity, gender identity, sexual orientation, age, or language background, can stay healthy. That's what this is about. We know that diseases such as cancer, diabetes, HIV, heart disease, and hepatitis continue to disproportionately affect African American, Latino, Asian American, Pacific Islanders, and Native Hawaiian populations. We must address the underlying challenges that prevent underserved communities from accessing quality health care. The Health Equity and Accountability Act is a critical step towards ensuring that all Americans have the resources and care that they need to not only survive, but to thrive. With your help, we will create a system of care that is reflective of the needs of each of our communities. Thank you and have a wonderful conference.